Dear colleagues, dear friends, good morning, good afternoon, good evening, wherever you are. I am Maurizio Ciaconi, the President of the European Society of Intensive Care Medicine. Our first marathon was exactly 2 years ago, when our community brought together clinicians and researchers around the world to fight COVID-19. 2 years later, thanks to the work of our ICU teams, of our hospital teams, the progress made by research, both in prevention and treatment, and thanks to citizens getting vaccinated, we are facing COVID-19 better. However, we must not forget that the pandemic is far from over, and we still have to support everyone, everywhere is needed until it will be over. The last years have posed massive challenges to our community. These challenges have shown the world the importance of intensive care units and intensive care teams for our patients, their families, and for our healthcare workers. In life, we cannot always choose our challenges, but we can decide how we respond to them. Solidarity as being a fundamental value of the response of our intensive care community. In recent weeks, the world has been shaken by the Russian invasion of Ukraine. We condemned it as we condemn every armed conflict. Thousands of people have died, many more are still suffering. The news reported that even some healthcare workers died. Millions of people had to flee their homes and are now refugees in other parts of the world. Our thoughts go with everyone who has been affected by this crisis and to their loved ones. And over the last weeks, we've been in continuous contact with colleagues from Ukraine, admire their passion and commitment to saving lives. We are learning from them, and we have asked them how we can support them, and we are doing everything we can to do so. This is not the only healthcare crisis around the world at the moment. Today, we will hear about war, about refugees, about COVID-19, about our ICU teams. We will hear from many colleagues and institutions and friends working at the front line and other global healthcare crises that are affecting so many patients worldwide. Our community can help and our society wants to help. Our strength is in our members' network and in our ability to develop training and teaching tailored to the needs of our colleagues. Following today, we will keep these alive solidarity webinars and other resources free to help the intensive care community anywhere it is most needed. Solidarity has been the fundamental value of our community's response, and it is needed more than ever now. It has been the driving value of our community over the last years. And thanks to the help of every one of you, we have demonstrated that education and knowledge can save lives. Solidarity is what we need now. Please consider donating or asking friends to donate to our Alive Fund to support ICU patient care worldwide. Due to a last-minute problem, a very good friend of our community, Ms. Sirpa Pietikainen, one of the co-chairs of the European Parliament Interest Group in Intensive Care, cannot be with us now, but I still would like to thank her for all the work ongoing to raise the awareness about critical illness and intensive care in Europe. So, without taking any more time, welcome everyone, and now let's enjoy the ESIC Alive Solidarity Marathon. Together, we are Intensive Care.
good morning, good afternoon, good evening. Welcome everyone to the ESICM Solidarity Marathon. This is a very important time for all of us, dedicated to connect all together and to report on global healthcare challenges. I'm delighted to co-chair this session with Professor Sophie Hamada. Sophie, good afternoon.
Good afternoon, good evening, good night, everyone, and welcome to this great session. We are really happy to open this session with a global health challenge. And let Ellie introduce the first speaker.
Yeah, I'm delighted to introduce our president, Professor Mauricio Ciaconi. You all know Mauricio, who is a full professor of anesthesia and intensive care at Humanitas Research Hospital and University in Milan. Mauricio has been very much involved in the COVID-19 outbreak. He's part of the COVID-19 Lombardy ICU network and a very important person in Italy, in Europe, and worldwide. Mauricio is going to provide an important lecture on whether will we be ready. Thank you very much, Mauricio.
It's a big question, and I think we can learn a lot about what happened in the last 2 years if we want to try and answer this question in the uncertainty of the world we are living in at the moment, also as an intensive care community. During a crisis, the common reaction and the most natural reaction is actually to wait for more information, to downplay the threat, sometimes to withhold bad news. You really try to downplay things, trying to explain maybe that we just have to wait for more data and that the situation is not so bad. But when new uncertainty comes along, when a new crisis comes along, actually what is really needed from a leadership perspective, it's about acting with urgency. It's about communicating with transparency, and it's about taking responsibility and to focus really on solving problems and engaging constantly on updates on the community you're leading on. I have to say, I'm very proud to be part of a large worldwide community of healthcare workers, of intensive care professionals. I think we really stick together during the beginning of the crisis and through the crisis of COVID-19. And this is a learning that I hope that we can bring with us also in the future. This is one of the reasons why we have this marathon today, is to talk about this uncertainty and to talk about the healthcare challenges that we are living in. For us in Italy, the big day of the COVID crisis, if we want to learn from this, was the 20th of February, when a patient tested positive in an intensive care unit. And that was really the beginning of what we now know was a tsunami of patients coming along. One thing that was clear for me from the very beginning was that in order to keep a team together, really education, training, simulation, and training together, sharing information, and during uncertain times is really one of the most important things that we can do. And especially as a scientific community that share research, that shares education, what we can do really is learn from each other, is to try to use training and teaching as much as we can. And during COVID, really, I cannot state enough how important this has been locally. I was lucky to have the support of my university. Within a few hours from the first patient found in another intensive care unit in another hospital, I was able to bring a simulation team in situ. And that allowed us to train 80 clinicians. The first team of people to manage the surgery would have come over the next days. It gave us the confidence to work and to feel more protective, even during a situation that we were not accustomed to have normally. And of course, during a crisis, it's important to share all the information that you have. At the beginning, from the Lombardy ICU network, we didn't have much information apart from the number of ICU patients that were being admitted to the network every single day. But just with that simple information, we were able to model this with the support of the Foundation Bruno Kessler in Trento and Stefano Merler, and we were able to see that could have been a big exponential rise in cases that we would have not been able to manage even with just surging ICU beds. And in this sense, this is the moment where we were asking also for public health measures, but this is also the moment in which we realize that really We knew that we were not ready when this happened, but we also knew that probably the world was not ready out there. And we had to communicate with transparency this to everyone. At the time, I was the president-elect of the society, and Joseph Keseshoglu was the president, a very good friend and leading the society through very difficult moments during those days. And speaking with Joseph, I said, really, we would like to try to share some of the information that we have from Lombardy, from Italy. And with Giacomo Grasselli and Antonio Pesenti, we wrote this letter, which you may have seen, and that Joseph sent as a presidential letter. And this was a simple message: get ready. No one is ready for what we know, and putting some preparation in place is really crucial now. So this is something we should not forget now. We really hope that the uncertainty and the healthcare challenges that we are seeing around the world now, also for the intensive care community, will get better. But we cannot just hope. We have to take action. And to take actions means that what we have to do as a scientific community is really to try to be prepared, to help where is needed, and really to try to do as much as possible. One of the first actions that we took 2 years ago was really try to bring scientific information, also to filter the disinformation and the confusion that was out there. I think this was very important. Members were asking us this, healthcare workers around the world were asking us this, and we were learning from each other. We were really putting together people so that we could exchange information and understand what was going on. An important role, I think, is also to try to not to work in silos, but to work with other institutions. I have to say I have a very good experience, and I will mention a couple of institutions today. One is the European Commission, but also the WHO. We had a very good experience with the European Commission because they came to us asking us what would we do after the first wave in case there is a second wave. And as we know, we've been in the pandemic now for more than 2 years. They were asking us what devices, what drugs to buy and to store and to get ready, personal protective equipment, and so on. And of course, we say it's great that you are working on that. But the important message that we want to pass is that a ventilator is not an ICU bed. We can buy all the devices that we want. But during unprecedented crisis, when we have to surge specific acute beds and intensive care beds, it's about people and it's about the team. An ICU bed is a group of competent people working together, caring for patients and families. And for that, we cannot find a specialist just in a few weeks or in a few months. But what we can do, we can train, we can give basic skills to those people that are deployed to the intensive care teams in the moment of need. This was the story behind the C19 Space, a COVID-19 skill preparation course funded and supported by the European Commission that we had the honor to organize and deliver. The goal was to train 10,000 healthcare workers before the second wave, or just before the first 6 months since we started in September 2020. And we trained more than 17,000 people with a track for doctors and for nurses. The most important thing for us was all the feedback that we received. People felt like they used this. And this was used, of course, different in different countries. We were not expecting that everyone would use it the same way. This was more to give an opportunity to those ICUs, to those countries that didn't have the time to work on training programs like this, to have something ready to go. Importantly, we were able to show that we increased knowledge. But as I was saying, the feedback that we received, the thank you letters, people saying, I feel much more comfortable going and work now during a surge, or the ICU saying this removes some burden from us. So we've learned a lot from this, and this is something that we want to carry on doing also in the future. Especially as a scientific society, we don't have the strength of the energy to deploy doctors directly, but we can provide our network so that we have a way to give the opportunity to people to help and to access information. And in this sense, we have a great experience also with the WHO. I have the honor to be part of this group, which is led by Janet Diaz, and with the WHO, we're also talking many times to see how we can join efforts to try to train and to teach more people. But again, what we've seen happening during the last 2 years in terms of research on the field, and how this research was shared and disseminated, and how clinicians and scientists were able to look at this research and put it together into an evidence that could be used at the bedside. Again, this is something that we have to bring with us in the future, and I think will be a very effective way for us to help where it's needed. We know that there is an ongoing crisis at the moment in Ukraine. This is not just about Ukraine. What we are doing today is about helping wherever it is needed. This is the reason why we started with the Alive Solidarity webinars. And this marathon today will have also some very important testimonies also from Ukraine. We spoke with our members and doctors and healthcare workers that we knew there. It's amazing what they are doing on the field, and we have tried to ask, what do you need and how can we help you? So we are also trying to bring this information and to work together to put a cohesive effort to try to help people. And what we've done was giving access to our existing educational resources. We have asked, how can we help you? We would like to help you more. Some things maybe we cannot do, but all the things that we can try and bring for you, we'll try our best to do it. And so, for instance, learning from the colleagues at the front line, we've learned that some of the most common difficult situations that they had to face also with team members that were coming and joining their teams were, for instance, triage in ICU or hypothermia. So we put together experts and worked on the webinar specifically for that. Today, we have this initiative in which we will talk and go through a series of topics that are very relevant for the global intensive care community. And we will carry on with these webinars, asking people, what do you need? How can I help you? And how can we learn from you being at the front line at the beginning for this crisis? So, in summaries, we will be ready. I think we learned that we were not ready for the major crisis that our generation of intensive care teams have seen, which was COVID. But what has been amazing is how we got together as a community to share information, to share research, to share teaching, to support each other. I think we've shown to the world that ICU teams are more important than any devices, and I'm sure that this team is something that will be very present in any healthcare crisis that we will see around the world. I think what we can do to be ready, we have to increase in ICU competency, foreseeing what may happen with some of these global healthcare crises, and not be scared of doing the preparation beforehand if we can. Still, we have to work in networks, clinical networks, but also research, scientific networks. And when we want to help, it's really important that we go and learn from the people that are there at the front line and ask, what do you need? And let's try and give you the help that you need. And really, let's try to share information. Let's try to stay united in solidarity. Thank you.
Thank you, Mauricio, for this presentation. And finally, with Ellie, we decided to keep the question all together in a common session at the end of the 3 talks, so that we can discuss with all the experts. So now let me introduce Dr. Janet Diaz, who is from WHO in the preparedness department. She's been working there for 5 years now in the unit head clinical management in Switzerland. And her job is to lead, develop, and coordinate clinical operational response strategies at global level, including strategies for healthcare workers, preparedness, and supply chain readiness. So Janet, this is your time to talk now.
Good afternoon, good morning, good evening, colleagues, and it's my pleasure to be here. I was asked to present a few slides on responding to global health emergencies, and I will try to do so as in a succinct manner, although this is quite a large topic. The 3 recent examples that I wanted to discuss that have one common theme is how to bring life-saving quality and safe care to patients during health emergencies. And obviously we've been doing this for COVID-19 pandemic for over 2 years. And I highlighted here some basic things, and I want you to see the common threads. Doing the basics well with infection prevention and control, integration of new diagnostics and therapeutics into their care pathways, optimizing supportive critical care, and I know the group here has a big focus on that. And then of course, following up for mid and long-term complications like we know has developed with COVID-19, such as long COVID. Ebola virus disease is another one that I am still working on in the background. And again, similar concepts here, doing the basics well with infection prevention and control, but this is a high threat pathogen. And those outbreaks have happened in settings that are much, with many resource constraints. So the importance of having safe structures to work in, integrating again, diagnostics and therapeutics, and optimizing supportive and critical care, following up for long-term complications. Finally, disasters and conflicts, and I raise this because of what's going on in the Ukraine. Again, doing the basics well with IPC is the common theme. Here, it's the trauma care and the damage control and patient referral systems that need to be put into place. And I'm going to discuss more about the management of displaced populations, the risks of communicable diseases in those settings, as well as non-communicable diseases and the lack of essential health services, and of course, mental health. For COVID-19, I just want to highlight our COVID-19 clinical care pathway. This you can find on our website, and this is a product of multiple colleagues and stakeholders and collaborators around the world that have participated to help us do rapid evidence synthesis, to do guideline development groups such as Mauricio, who's on our GDG panel, and helps us bring evidence generation to practice guidelines that can be used simply. And the care pathway is simply the way that we're trying to visualize the best care at this moment in time for COVID-19. I want to highlight the normative standards that WHO has developed for COVID-19. One is a therapeutics and COVID-19 guideline, and that has had 9 updates since the beginning of the pandemic. So we try to keep up to date. The last one published in March. And we've had 3 versions of the clinical management COVID-19 guideline, the last one published in the 23rd, and one that's soon to publish. I want to say the first life-saving medicine we had for COVID-19 was oxygen. And of course, that's the basic bread and butter of ICU medicine. And the second was for corticosteroids, a widely available drug. And in that first clinical management guideline, we did include best practices for critical care. And I hope you guys have all had the opportunity to read that to make sure that the basics were done well. Since then, we've advanced, and our guidelines are disseminated in multiple different platforms. One is in the BMJ journal, where we have a very easy to read infographic that's on the left. The second is in the MAGIC electronic publication platform, where you can actually just look online at our different recommendations. And then on the right, you're going to see various different types of dissemination pathways, which is really important to get this information to clinicians. One is the COVID-19 clinical care pathway. We have a website for that. Second is a case management webinar series. And the next one we're going to have, which will be in May, will be on the management of patients with severe COVID-19 and critical COVID-19. So we do hope you can join us for that one. The third is a SARI toolkit, which is a compilation of tools and algorithms to care for patients with severe acute respiratory infection. We have training platforms on OpenWHO, and we are linking our work to pharmacovigilance studies for the new oral antivirals. So not to be repetitive, again, the corticosteroids was the first drug that we recommended, but to date, we have other tools in our treatment toolbox, including IL-6 receptor blockers, baricitinib for severe and critical patients, and molnupiravir, which was the first oral antiviral that we have for non-severe patients. And soon we'll be writing recommendations on nirmatrelvir and remdesivir for that same patient group population. In the slide, we also have the 2 monoclonal antibodies, but unfortunately, we all know that casirivimab and devimab efficacy and preclinical studies is lacking for the Omicron variant, and sotrovimab as well, lacking for the BA.2 variant. So we have to keep up to date and keep updating these so that clinicians know what to use and when to use and how to use these drugs. This is just a look at the website. You can see the timelines of our guideline development, so you know exactly when the GDG is meeting and when we expect to publish. We are looking right now at the data on anticoagulation at the different doses, and do hope to have that publication sometime in May. On the bottom right, I have noted that non-invasive ventilation, high flow, are in process of being evaluated and drafted as we speak. But what else? One of the biggest problems when COVID-19 highlighted the inequities in access to oxygen in low and middle income countries. This was not just to oxygen, because as Mauricio rightly pointed out, it was also limited access to biomedical supplies and workforce. That meant the clinical workforce and the technical or the biomedical workforce that was able to work collaboratively in the multidisciplinary fashion to provide safe care with oxygen and advanced respiratory support devices. So WHO and its partners have worked extensively over the past couple of years on an oxygen scale-up initiative. And that has helped build oxygen generation plants in some very resource limited and remote settings, and improve distribution mechanisms within countries, alongside investments in medical equipment. But again, working to build the workforce capacity is key, including clinicians and biomedical engineers. We also launched an O2 COVE2 study, which is actually looking at oxygen use and availability for patients with COVID-19 in about 36 sites in 24 low middle income countries. And we are also working with our partners on looking at how we can monitor the key performance indicators for the investments made in oxygen scale to make sure that those millions of dollars that were spent all around the world are going to use at patient impact level. This is just a slide showing a little bit of the total numbers between multiple agencies, UN agencies, and other NGOs spent in the biomedical procurement field, over $305 million spent in 153 countries. But again, highlighting the importance of training on safe use and appropriate use. There still remains plenty of R&D priorities for COVID-19, including understanding post-COVID condition, long COVID, burden of disease, natural history, treatments, the continued evaluation of the best supportive care, optimal supportive care interventions, prognostic models. We've had a hard time identifying how to best prognosticate on patients, especially as we have new variants, as well as increasing vaccination, so the risk of an individual patient changing over time. The importance of standardized tools and data registries. This something goes beyond COVID-19. For the next outbreak, do we have standardized data collection toolkits, CRFs, core outcome sets, something that allows us to better aggregate data, synthesize data, and use that to inform public policy. And then knowledge uptake. How can we get this evidence generated, which has been remarkable in COVID-19, synthesized, graded, with the grade methodology, and then transformed into a guideline, but not stop there, also transformed into tools that countries can implement. And I do want to highlight one thing here about operational research, a big need to see our guidelines and recommendations being applied. And then there's not a point here on access, but I do want to highlight, we've seen the access at the beginning was for oxygen, limited access in many places. We've seen the limited access to vaccines, the big problem with inequities there. And now we are seeing as well the limited access to therapeutics. So aside from corticosteroids, the others are complex are not yet widely available in many resource limited settings, and that must change. I'm going to step on the next few slides are just a couple on Ebola clinical management so that you don't forget this. I think everyone can remember the outbreak of Ebola in West Africa, 2014 to 2016, where there was a pooled case fatality rate of about 60%. And I want to highlight there were some patients that did leave West Africa and were evacuated to US and Europe, where they did receive intensive care management. And the case fatality rate in those groups were much lower. And so here, I just want to show you the evolution of treatment units for Ebola over time, and trying to show you what was available in 2014 in Sierra Leone, in Kenema, and then what was available in one of the hospitals in London. So let's fast forward here. Where are we now? Actually, we've advanced quite a bit in Ebola care management over the past few years. We have had outbreaks in Guinea and in DRC, which were the biggest ones in the most recent past. But what have we advanced to? We have more safer, biosecure Ebola treatment units. And they are allowing us to provide more optimized supportive care, meaning we can provide oxygen therapy, intravenous fluids, vasopressors, the basics of critical care in a safe mechanism, and also make sure that we can take care of pregnant women safely and that there's more community acceptance of this. And that's been a big focus of WHO and its partners' work. The second is optimizing supportive care. Again, going for the ABCs of doing good resuscitation and how we do that using point of care testing, something that we would take for granted in certain settings that were practiced, but something that were not available in the previous outbreak in West Africa. And also the use of transfusions for patients who were having massive hemorrhage. And finally, Ebola-specific therapeutics. We do have 2 drugs were tested in a randomized controlled trial, hallmark trial entitled the PALM trial, conducted by the NIH, and that found 2 life-saving treatments proven for Ebola virus disease. And there they are listed. I'm going to use the short names NAB-114 and Regeneron, which is a monoclonal antibody cocktail. So what to expect? WHO is updating its clinical guidelines at this moment, and they will have strong recommendations for those 2 monoclonal antibodies, and also working on its case management training package, which is multidisciplinary in nature. My final slides on the Ukraine complex emergency. We know how complex it is. It was very nice for Mauricio on behalf of ESICM to come and offer support to WHO and other partners during this emergency. We know, what does it look like? It's a complex emergency. These are always very complex to manage. The health risks are huge. So trauma and injury obviously can swiftly overwhelm pre-existing health services. So one has to develop and put into place robust referral pathways from stabilization to referral to rehab. And this is a complex system to put into place, but with emergency medical teams and other, if countries were ready for this type of conflict, they are able to scale this up and put this into place immediately. However, the disruption of the healthcare system, both the primary and acute care disruption, can result in other problems to the population aside from trauma and injury and treatment interruptions. And this can, in general, lead to declining outcomes for patients from non-communicable diseases and chronic disease management. Infectious disease outbreaks can also occur. We know we have displaced persons, so there will be an interruption in water services, hygiene, that can lead to outbreaks, disruption in access to vaccination, again, leading to outbreaks, and difference and challenges in living circumstances and access to essential health services. And the last bullet here is about the direct or indirect impact on psychological and mental health due to the conflict, violence, and displacement. So what are the health priorities in this type of complex emergency? Make sure you have care pathways for the threat. In this case, it would be the trauma surgical care pathway, which was prioritized, obviously. And then, of course, in this case, as well as potentials for chemical hazards that need a response. Establish supply chain for life-saving medicines and equipment, and make sure that we can get those life-saving equipment such as trauma kits and oxygen to patients on the front line and to the operational facilities. Preserve, adapt acute life-saving and essential health services to maintain the care of patients or of the care of the population, and hopefully prevent development of illness, and maintain the supply chain for chronic disease management, introducing simplified care pathways as needed, and maintain disease surveillance, and be aware of new and old infectious hazards. So here in this situation, making sure that there's pathways for COVID, for influenza, and hopefully not to see any outbreaks of any other infectious disease. So in conclusion, healthcare readiness is essential to be able to respond quickly to emergencies. It should be a response that can activate immediately and scale up as required. Think about your staff, your supplies, your structures, and your systems. Clinical care pathways need to be available for the threat. For new threats such as a novel infectious pathogen, evidence generation, translation to patient care pathways needs to happen fast, but be trustworthy at the same time. And basic critical care interventions can be applied from the onset and optimized along the way. And coordination, solidarity, and humanity is necessary for impact. So with that, I want to thank you for this opportunity.
Thank you very much, Dr. Diaz, for this outstanding presentation. Very, very impressive and inspiring lecture on healthcare emergencies. Well, as said by Sophie, we will group the questions after the third presentation, and I'm delighted to introduce Professor Katarzyna Kotwis from the Pomeranian Medical University of Szczecin in Poland. And thank you very much, Katarzyna, for your lecture.
Good afternoon, everyone. My name is Katarzyna Kotwis. I'm a professor at the Pomeranian Medical University in Szczecin, Poland, and I was kindly invited by Professor Mauricio Ciaconi to present a brief lecture regarding helping during humanitarian crisis. Humanitarian crisis in year 2021 have been multiple, but year 2022 has brought a major attack from Russia onto Ukraine, and the information of the 28th of March has shown that from the total population of 42 million people affected, as many as 18 million, those in need 12 million, and those who have been internally displaced is close to 7 million. Now, what are the health risks during migration for those that need to be transferred to different places? There's the before migration process, during travel, and at transit and destination. So before the migration process, there was no implication of need. There are multiple problems during travel, including border crossing, environmental elements, including the weather conditions, different attempts of problems of violence during border transfer, unsanitary conditions and overcrowding, inadequate nutrition, and poor personal hygiene and food hygiene. Now, at transit and destination, the major problem and the major issue is the adaptation to new life and surroundings, and of course, culture and usually new language. So, first of all, the problem of the legal status and many overlapping conditions, environmental conditions, social factors, lack of access to healthy food, issues related to social problems, including. Now, what regulates the help for refugees and those people who seek asylum are the laws gathered into international humanitarian law that set rules that seek to limit the effects of an armed conflict wherever it happens around the world. And it defines the passage of humanitarian aid, which has, as we have seen, been impeded in many places, the freedom of movement for humanitarian workers, those who come with help, protection of civilians that has always been regulated by not only European Union, but international humanitarian work, and protection of refugees, prisoners, the wounded and the sick. And we have recently seen that these laws have been breached. Now, when we talk about problems for refugees and asylum seekers, we always have a range of problems that can be divided into those immediate and those that are long-term. So poorly controlled chronic conditions among the first group, mental health and specialist support across all age ranges, maternity care, and untreated communicable diseases. Now, a very important element that would aid providing qualified help is to adapt to language barriers and adapt to language translation needs. Now, what we're seeing right now with the current conflict and recent immediate problems that are visible for those crossing the border from Ukraine to Poland are those associated with long travel, crowding and confined spaces during transfer in trains and cars, and rapid evacuation, leading to lack of medication for long-term diseases. And the most common problems are those of gastrointestinal disorders, flu-like illnesses, sore throats, urinary tract infections, also hypothermia, especially for the young ones, for the children, cuts and bruises, wound infections, obviously exacerbation of chronic disease and that diseases that has already been mentioned, and those associated with the problems of COVID-19. Now, chronic conditions, first of all, poorly controlled chronic conditions like diabetes or hypertension, which are the result of long periods without access to regular medications or loss of medications during transfer. Exacerbation of renal failure, heart failure that might necessitate immediate admission to an high dependency unit or intensive care unit, injuries or chronic pain and disabilities, but also dental and eye issues that may cause discomfort and impairment. Now, maternity care is a special situation because pregnancy might be the first significant contact that the female might have with the healthcare system, and it is also a good opportunity to engage women to the healthcare issues. A major challenge when the load of refugees seeking help is very large are the housing and social problems that are associated not only with the place of birth and admission to the hospital, but also with the elements of related to discharge after birth. Now, another problem here that has been raised by many humanitarian workers is malnutrition and need for welfare support, monetary support. Now, communicable diseases, screening for infectious diseases that are common both in the receiving country and from the country that the refugees are fleeing from, might be different. We need to identify symptoms of communicable diseases and discuss the screening programs and the consequences of the screening program. Also, a possibility of receiving a positive result must be discussed. The vaccination rate between different countries, as for COVID-19 or measles, is different. So information should be offered, and any missing vaccinations should be put onto the immunization schedule. Catch-up patients with uncertain or incomplete vaccinations, this is our job to do so. Some patients will need health education and, of course, appropriate language explanation. As for mental health, many refugees are at increased risk of mental health problems associated with war trauma that ranges from anxiety through depression, post-traumatic stress disorder, and severe mental disorders. Therefore, there must be a major pressure put for avoiding unnecessary referrals, but also for providing qualified care for those patients. Patients with trauma, both psychological trauma and physical trauma, might fear medical medication examination, might need special medications to ease off anxiety. There might be a feeling of shame or humiliation in disclosing problems into a relative stranger, as is the new medical officer. Of course, problems of human trafficking and slavery must be mentioned, and sexual violence at the war zones has been highlighted many times and has been highlighted during recent aggression from Russia and Ukraine. So the healthcare providers must be ready to provide specialist support and screen for health conditions affecting those patients that are subject to sexual assaults. Now, it has been shown through different conflicts that up to 50% of asylum seekers might have experienced torture, and these might be physical and mental consequences. Both mental health problems arise from that and sexual abuse elements as well. So all of that must be identified and screened for. Now, what are the solutions? The adaptation strategy, which frames the issue of migration as a normal and constructive response for societies, from societies to those who are refugees, require providing policies that are based on equity and social justice to accommodate the needs of migrants and refugees, to provide a full full range of health services that is accessible to the general population at place. So here, international collaboration is necessary between governments, between countries, but also support from non-governmental organizations. And there is a number of organizations that have been identified in helping refugees and those people who are seeking asylum. So this is a major international cooperation that requires both the country that is under attack, but mostly those countries that are receiving countries. One element that arises from this, as a problem for the policymakers, is that some conditions related to the organization of healthcare might be new to those who are guests in the country. People are unaware of the way healthcare is organized in the receiving country. There might be expectations to be referred to a hospital, whereas in the receiving country, many healthcare problems are dealt with by the general practitioner. So the explanation of the primary care and the hospital care must be provided. Now, there are some needed interventions to ease off cultural and environmental problems. So there must be policy measures to tackle social determinants for migrants, and that means reducing barriers at the labor market, combating social exclusion, providing adequate housing, and reducing occupational hazards. Communication barriers have already been mentioned, so we should consider not only the language, but also the gender and sexual orientation. We should provide support from local organizations, and doctors and every healthcare practitioner should develop transnational competences in accommodating different cultures. Now, those helping might also be at risk, as healthcare professionals and other staff is exposed to trauma, to burnout, and so appropriate education and training is necessary, with regular debriefing and professional counseling from the peer group, but also from professional and psychological and psychiatric help. To sum up, the general needs there's a whole list of general needs, from communication-oriented to welfare and health and well-being of the migrants. a very important element is to hear the migrants, the refugees themselves, and to accommodate their needs into what can be provided and what they're actually looking for. Of course, our job is to expand the education and training of healthcare professionals who work with migrants and refugees. So, moreover, research agendas are necessary to address the migrants' health and well-being and needs. We should also encourage academics from different universities and different backgrounds to speak out, to interpret the facts and policies, and to allow for cooperation between both the migrants and refugees, but also professional associations in the receiving country. With that, I thank you and hope for a quick resolution of the current conflict. Thank you very much.
Thank you very much. We have had a wonderful lecture, inspiring and at the same time full of energy and very good perspectives. I really share what you just said, Katarzyna, that we all have the same hope that we will be outside the conflict and outside anywhere as soon as possible. No one benefit from anywhere. Sophie, we have these wonderful presentations and some questions to ask. And maybe you want to start to ask the question to one of the three speakers, or one for the three?
Yes, of course. So let's begin with you, Mauricio. So your talk was, will we be ready? And I don't know what you think about a next pandemic or a next experience as we have been living in the past 2 years. What we have found the more difficult as doctors is at the same time triage information arriving, because you say we have to share the information, but sharing information, and we have been overflooded by information, and we had at the same time to run the hospital and to keep in running the hospital and be able to triage the information, and we cannot delegate that to everyone at least. So how would you advise us to do so and to deal with that? Because we all made mistakes because we do the wrong choice at the beginning with all this information.
So it's a good question, and to be fair, I think it's a question where I should say that we need to take the responsibility as scientific societies to filter that information. That was one of the missions that we had at the beginning. I remember even the first patients coming to our ICUs, and a lot of people outside saying this is just a flu, and what's happening in Lombardy and what's happening in Wuhan is not going to happen in other cases, and so on. And not to mention all the anecdotes and the hydroxychloroquine or ivermectin use without any evidence. We're seeing a lot of that. I actually think that is exactly the role of scientific organizations to filter that information. That is certainly what we have tried to do. Exactly for what you're saying. We were all so busy that no one can do that alone. That's why we need to put together the efforts and do that. And I have to say, I have two hats here. I'm the president of the society, but I also work with the group led by Janet Diaz with WHO. I think the WHO has done an incredible work with the clinical guidance, exactly to filter that information at a very high speed, to be able to bring practical recommendations at the bedside. And even before that, what we achieved with recovery, with REMAP-CAP, Solidarity, those infrastructures, they have to stay in place because we have to carry on learning while doing exactly to get rid of bad information and to bring the best at the bedside.
Thank you, Maurizio. I have a question to share with the three of you. And I must say, I have been very impressed by one of the common points of your three lectures, which is hope. That's incredible how much we are close to a pandemic that has been very, very bad for all of us, now a war, and we can find hope in any of your words. in managing humanitarian crises, healthcare emergencies. You, Maurizio, as the president of the society, running since February 2020. So let's see how this can translate into our colleagues involved in the conflict and listening to us today. I think that the biggest message that is here is that we are here with them and we are here for them. So I would like to listen to you on this specific word. We have colleagues that are very sensitive and very touched by this initiative. What are the words that you want to convey to them? Maybe the president should start?
I wanted to give the word to the others that didn't speak.
Of course.
But if I can just say one word, we choose very carefully the word for this series, and I think solidarity is really what we need. Solidarity is what brings you close to other people. Sometimes even when they cannot physically help you, but they make you feel you're not left alone, and that gives you hope. And I had that on my skin 2 years ago, and this is very important, Ali. So I think you mentioned something very important. You know, we often say together we are intensive care. It's about staying united, because we can share all sorts of help, and sometimes even just sharing what we feel and how the situation is going is very important. And I think our community has demonstrated this over the last 2 years, and I'm confident that with solidarity, there will be hope.
Janet, Katarzyna?
Yes, I think it is very important what Maurizio just said about solidarity, and I fully agree. I think that it will not be good to say that COVID-19 pandemic has prepared us for anything, but I think that the networking that we had throughout Europe and throughout the whole world regarding COVID-19 is paying off right now in all populations. In Poland, as we have received many refugees during the conflict, everybody was ready to act and work, and I think that COVID-19 has trained us to do that. Not only within the ICU committee, but within the whole medical field. That is one thing, and also the need during the pandemic to increase equipment and workload. As I said, is paying off now, because we are ready, or more ready than we would have been, to accommodate those needs. But to me, the solidarity part and the networking across countries is the key element to be able to help.
And I guess I will go next. I agree. I think the messages are that you are not alone. So the solidarity message rings clear. I think also trust, trust your peers, trust your colleagues, be humble. We all don't know the answers, and we have to accept that humbly. We have to always be learning and listen and apply critical thinking, but be humble. And probably one of the most important things is to have compassion and empathy with yourself. So be kind to yourself and be kind to others, even when things get very rough. And rest, take a deep breath, and approach each day with some fresh eyes, even though the challenges may still be large. Thank you.
Thank you very much.
Thank you. I would just like to ask, can you hear me?
Yeah, very well.
Okay, very good. To go on a little with this question, and to ask you how you manage the frustration and the period between what you recommend in your different talks, all this hope, solidarity and connection, and what is the reality and the time it takes from what we know, what we have to do, what we should do all together, and the time we manage to build in and put it in place so that it works. That's so frustrating and so difficult when you are a caregiver. So maybe you have some inputs on this.
Katerina, if I may, I have a question for you. I have, a real full admiration for how the colleagues from Poland have welcomed the refugees, and not only in numbers, but also, you know, families with mothers and kids trying to have normal lives and to, you know, to save the appearances. Please, as it's very likely that all of us will have to do that, and all of us are committed to do so, how you and your colleagues and people living in Poland have felt, what were the major needs of people coming to Poland, and any advice that you can give us for us to get prepared to that?
Yes, the answer to that question is multi-layered, because there have been immediate needs that I have mentioned, and as people were crossing the border, and these were high volumes of people entering Poland, the needs were very simple. There was just lack of fresh water. The children needed immediate packed food, but also sanitary needs had to be fulfilled. Another group is a group of those patients who are chronically ill and are transported across the border with a targeted response. And this group, as within the refugee group, 1 million children have fled to Poland. Within that group, there is a very large group of children who have special needs, and these has been. This is why I mention it, is because these were targeted, so to say, organized transport of orphanages with different psychological needs, but also for those children that are under oncological and hematological help. So those children, or metabolic diseases. So those children were transported to targeted sites that then decided where to further treat those children. And with all the other patients, when we mentioned the maternity care, very quickly health GP practices and also hospitals have organized dedicated sites with translators coming from the migrant sites, but from the migrant side, but also we had many Ukrainian people working in Poland before the war started. Even before the war started, so it was easy to recruit those translators from the group of people who were actually residing in Poland beforehand. And I don't know if you, in other countries you will be seeing that, but we had like a reverse migration. Before the war, there were many men working in Poland in many fields, and their families were in Ukraine. Now the movement is transversed, so all the families, the mother and the children are here, and the men are back in Ukraine. So it is a different population to care for, with a focus on children and maternal needs. But also there's an elderly population that needs chronic disorder help. There have not been many people admitted to the intensive care unit, which is very good. And also the pediatric ICUs are not seeing a large number of admissions. It is rather the pediatric wards.
Thank you very much, Katerina. Sophie, I think that we are reaching the end of this first part of the Solidarity Marathon webinar from the ESICM. I think we have learned a lot, and I have been delighted to hear to the three of you and to share this session with Sophie. Sophie, maybe some last words for the session, and then we will transfer to the second part.
Yes, thank you very much. It was a great opening, and I think we have to remind that we are all together. The words for this session are solidarity and hope. Thank you very much.
Thank you. Together we are intensive care.
Thank you. Bye-bye, everyone.
Thank you. Bye-bye.
Bye-bye.
Hello, everybody. Welcome back to the second session of our live Solidarity Marathon. And together with my co-chair, Marlies Osterman, it's an honor for me to chair this session, which is about critical care challenges during war. We have 3 talks. I will introduce the first speaker. That is Maxime Pilipenko. He is Associate Professor of the Department of Anesthesia and Intensive Care of the Shupik National Healthcare University of Ukraine. And also he's head of the ICU department at the Romodanov Institute National Academy of Medical Sciences. Dr. Pilipenko, please, you will update us on the front line in ICUs in Ukraine.
Good afternoon, dear colleagues. First of all, I would like to express my thanks for chairmen and for ESICM president and organizers of such webcast, for constant support for Ukraine, for all Ukrainian intensivists, and for inviting me to speak at this webinar. First of all, I would have to say that my neurosurgical institute is not the first line hospital for admitting of injured patients, and we are not overwhelmed to treat them. So I contacted several colleagues for different regions from different hospitals, and even hospitals in occupied zone, and I am thankful for many colleagues who shared their knowledge, their experience, their expertise, and agree to me to share their knowledge for all European colleagues. And for security reasons, majority of photos are from open resources, and I will not, let's say, acknowledge the many important names for who were involved. First of all, I would like to underline that our president, the leader of our country, support medicine, support ICU, especially those hospitals who are at first line. And he visited a few the most important hospitals. And on the back of the slides, we could see the chief of our ICU for military hospitals, a well-known guy who is very experienced, and patients are in good hands. And on the right screen, we could see some machine for hemodialysis, and the clinical point for hemodialysis in massive soft injury we will discuss shortly at the end, close to the end of the presentation. Another prominent hospital, Kyiv Thoracal Center, maybe one of the most experienced hospital to treat injured patient and combat since Maidan or even before that. And such hospital is always ready, very nice surgeons who is able to stop bleeding in a few minutes, to open chest, to open abdomen. But intensivists also have to be prepared. And on the left picture, you could see the windows that covered by some film, fluid with adhesive film, with some boxes. Respirators are prepared. On the right slide, some bottles. Obviously, it has to be warmed up solutions. Bottles have to be primed with some hemostatic agents. But the point was to have already prepared blood, we will discuss at the end of these presentations. From this, the same hospital, the leading physician, Professor Dubrov, who is also the president of Ukrainian Society of Anesthesia and Intensive Care. He is a clinician as well, and he himself doing tracheostomy, but even in such a high-level hospital for, let's say, save the light escaping from operation room, from ICU, for insulating from the light. He performed tracheostomy in the, let's say, not enlightened room, and some colleagues just switch on their mobile phones to help him, and such situations are quite common, especially it was in the first week of innovation. And next part of presentation, I would, in contrast, to show some hospitals that are working in some terrible conditions, some austerity, regional austerity hospital, and you know, if you are in ambulance, it's not defending you. Sometimes ambulance is primary targeting from aggressors, and also it's from Kharkiv region. But just yesterday, my friend and colleague neurosurgeon who were in ambulance to deliver medicine, some disposal to surrounded Chernigiv, his ambulance were shot up. Nobody was injured, but the mission was failed, and everybody was gravely disappointed of that. And this story has no happy end. Our colleague Marina was shot up when she delivered her patients, when she evacuated her patient, and let's remember such people, eternal memory, and God's kingdom for everybody who sacrificed his or her life for our future victory and for our future life. And I would say that several hospitals are occurred on occupied territory. It's usually I contacted with several people directly, even in my department. One surgeon worked, and when she was in such a hospital, military guys came to ICU, pointed out some guns. They asked some question. Usually it's the work of hospital is interrupted. The evacuation of patients are usually or time to time forbidden. Even it's allowed, it's extremely dangerous, because several times such ambulatory ambulance were shooted out. And if evacuation is impossible, the situation is progressively aggravating. In few days, it's extreme shortage of blood, medicine, disposal, and so on and so on. And near 100 hospitals were more or less damaged. If before admitting patients, you must decide some organization issues, such as closing the broken windows, organized electricity, backup electricity, some heating, some water. Everything has to be secured, and only after that you could start medicine in our normal understanding. Emergency medicine, emergency department are overcrowded, often overcrowded, but even in such cases, every physician must be focused on the quick revealing of source of hemorrhage and other things that could kill patient from, let's say, ATLS algorithm, primary survey, and so on. And time to time, the work is performed in the darkness and only with mobile phones, because at least at the first week of such conflict, many such lights and many hospitals were primarily targeted for enemy military. Even maternity hospitals changed their work, and in Dnipropetrovsk, in Dnipro now, they went to the basement of the building. It's a bit messy, and even if they were concentrated on very sophisticated care for patients, now the care shifted first to warm it up and to feeding, and only the third place is meds. The same for ORs in such hostile environment and some regions where conflict is ongoing. First of all, you must cover the window with some fluid adhesive films or some, we called it scotch, such normal types of adhesive film covered for light insulation. You must prepare some disposals and so on and so on, and only that then try to accept patients when you're ready. If you're ready, usually we focus it in civilian time on the ABC, and airway is always our priority. But if you have a mass or multiple casualty, sometimes you have to find compromise, and for some wound debridement or for some even small operation, you must keep, or it's better to keep your patient on spontaneous bracing. And right pictures is my colleague and friend, Dr. Niedoszkowski, from the chair of anesthesia and intensive care of Shupik University. And another thing, it's from Zaporizhia, that ICU is so overcrowded. The same level of protection, even stronger with sack, with sand, and also ICU looks as a bit messy and like controlled chaos. Someone must oversee all process and constantly assessing and reassessing patients to find out who is require some operations and so on and so on. Now it's Kharkiv, the same protection first, and then medicine treatment, and you always have to have plan A and plan B for patients' evacuation, and sometimes or even often it's considerable problem, but you must decide it even when it's problem, but not waiting that for 2 times that it's impossible, and you must assess and reassess the ability for patient to be evacuated. And a few things for the reason of stress. Many doctors and especially nurses are working since the start of the conflict at the first-line hospitals. The emotional state were so high that after that it obviously would be tiredness and exhaustion and even emotional burnout. People have to have some rest, but it's not always possible. All medics are human, and they have their own relatives injured, maybe friends, maybe lots of accommodation. And if you couldn't help patients for some extent that it was just a few days ago was possible, you obviously also exhausted and disappointed so far. And another reasons, just direct reason for lack of staff, because people could bring their relatives for evacuation, but just in 1 or 2 days it was impossible to return to your hospital. Another problem, even in Kyiv, it's the major problem that our nurses are living around Kyiv, and such rural area or sometimes towns are occupied much earlier than big cities, and many doctors are living in cities, and it's like no shortage of physicians, but big shortage of nurses. And some physicians, male nurses, were mobilized or were volunteers. And concerning volunteers, we are so dependent for all volunteer support, especially around the world, and our volunteers are also working around the clock. And ICU physicians are the primary endpoints, doctors who make decisions, who are on the top of pyramid of decision making in terms of what medicine, what disposal, what equipment the hospital need now. And at this picture, we could see two nice Lviv ICU physicians who are not working themselves, but also organized all lines of supply for over Ukraine. You know, we have to at least mention a few clinical issues or items. It could be a separate presentation. We just cover up some problems. And in Ukraine, we have like somehow regulation that were established a few decades ago. We can't easily use universal blood group O or 1, as we used to say, and plasma group AB, or it's 4 for our calculation. Before you put first drop of the same group blood, you must let's say check patient blood, then ask blood from local blood station. Sometimes they even ask hemoglobin level. Previously it was obliged, it was obvious, but now a few hospitals escape such unnecessary things. But at least we must take blood, make patient plasma, make direct compatibility test. It's also possible to have two blood of patient, one drop blood of patient, one blood of drop of erythrocytes and mix up, but usually we obliged to do the comprehensive procedure with some microscopes, and sometimes and it's time consuming, and it was rarely then we could drop the first drop of blood earlier than 60 minutes. And all military medicine over the world use such live living blood banks as fresh or warm blood, but we are just in the process to make it allow it. And one publication I must cite, it's very recent, just 2 weeks ago. They analyzed conflict in Syria. Some British physicians summarize experience, and according to this article, the vast majority of even severely injured patients receiving of whole fresh blood in very small amount, 1 or 2 doses, rarely 3 doses, and even the hemoglobin was like a 60. For patients who came alive to OR, the vast majority was alive or were alive. So another question just to discuss, if surgeons are so insistent to do it everything as in usual life to stitch the wound, sometimes it's the lead to compartment syndrome. It's not obviously visible such syndrome, but as ICU physician, we could experience more patients with renal insufficiency and who demanding requiring dialysis. And in terms of conclusion, we are united around our patient. All Ukrainian ICU physicians are courage to make some constant care even in austere environment, because we are believing in God's help. We are together, all Ukraine and physicians are at the front line. We certainly and totally believe for our military, and we believe in our victory. Let's say, practical support and humanitarian aid is very important, but last but not least, it's the moral support. We feel that over the world are with all people are with us, and such activity as solidarity webinars are so helpful for us. And even now, it's hard to be present for many Ukrainian physicians online, but certainly we would look at for such presentations later on. And just to show up Ukraine as a dark point over the map of for the Europe, because all of us are united not to switch on our lights at evening, but we believe that very soon we will have lights, and we will be stand up over our enemies. And we hope the good will win over the evil, and we will be, let's say, meeting together and speak on such terrible things as in the past. Thank you very much, and thank you for your support.
Thank you, Dr. Filipenko, for this very impressive story and very impressive photographs of the situation in your country. Our support really goes out to you. You really describe a very challenging situation. And you also described the shortages and the problems in distributing the people to other parts of the country which may have more resources, if I understand correctly. And I was wondering whether you are able to redistribute supplies from other hospitals, including blood, to the ones that are most in the front line. Is this being tried or being tried to set up or organized?
Not we, but our military, our volunteers are constantly trying to do that. Many doctors are volunteers and risking their lives. And today, one doctor who just yesterday were returned from such mission were in high emotional state because his ambulance was shooted. But we united, and he is keen to continue such doing of things and trying to deliver the aid for the point of care where it the vital necessity.
Is there also a shortage of oxygen?
Not so far, because we just after the COVID era, and at the beginning of COVID pandemic in Ukraine was extreme shortage of oxygen, but we spoke out about such a problem. We, let's say, doing our best to calculate the necessity of oxygen, and up to now, oxygen not our primary problem, at least in normal hospital, but in hostile environment, it could be shortage of anything and everything.
Are there any questions from the audience or the other panels? If not, I would like to thank you very, very much for sharing all these impressive experiences. And,
thank you very much. Thank you.
I would like to express my thank you as well. It's difficult to imagine what it's like to work under these conditions, and my support goes out to colleagues who, as we've just heard, risk their lives to save others. It's my honor to welcome the next speaker, and it's Professor Mathieu Boutonnier from Paris, who is a French military intensive care practitioner. He graduated from the Faculty of Paris in 2012 and was appointed professor of the Val-de-Grâce Military Health School in Paris in 2019. He heads the intensive care unit of the Percy Teaching Military Hospital in Paris and was deployed several times in military operations and is a recognized expert for the care of the wounded by weapons and war. And today he will give us a summary related to the care for patients with penetrating and blast injuries. Thank you, Professor Boutonnier.
Thank you for your invitation as a speaker at this Live Solidarity Marathon. So, first of all, I will disclose that this is my own point of view and not the French Medical Health Service point of view. And we will now talk basically of penetration and explosions. So my aims are to convince you that combat casualties are typically suffering from penetrating injuries, and that combat casualty care aims to save life and to preserve function. And as we have just seen, hemorrhage is the main cause of death of avoidable deaths among combat casualties. And the strategy we use to prevent this avoidable death is damage control. So some words of epidemiology. Our case fatality rate in asymmetric conflicts is very low today. It is so low because we are fighting in asymmetrical combats, because the protective effects have improved, and also because we mostly have air superiority that allows a rapid transportation to of the patients to the surgeon in order to stop the bleed surgically when it is necessary. So these are the lessons, but the main lesson is that mortality is very precoce on the battlefield, and 80% of the mortality occurred in the first minutes. So these lessons are also today true, and there is a window of opportunity to save life and to fight avoidable mortality. And this window is on the battlefield, and it aims at using tactical combat casualty care to stop the bleed, use tourniquet, use compressive dressings, realize airway cleaning and airway permeability. And the second concept of management is the concept of golden hour. That means that time is our enemy, and that particularly for the soldiers of the injured in the thorax, we have to treat them the most rapidly surgically in less than 1 hour. So this is the golden hour concept. And we have to transfuse also, if possible, in the pre-hospital time, and to perform resuscitation on the basis of damage control resuscitations all along the management of the casualties. So in death, we know that one death of 4 is avoidable, and among this avoidable mortality, hemorrhage is the main cause. As we've just seen, it accounts for 90% of avoidable mortality, and the 10 other percent are part in airway obstruction for the 8%, and 2%, excuse me, in tension, pneumothorax, and tamponade. And we have to know how to exsufflate these tamponade and this pneumothorax, performing thoracostomy. So now some words of the lesional, the mechanism of lesion and the conflict type. So explosion and penetrating injury account for 90% of lesions in recent conflicts. And if we look at the hierarchy conflict, for example, during the phases of maneuver, there is more penetrating injuries, it's about 43% and 48% respectively penetrating explosion lesions. And when the insurgency comes, when the conflict is stabilized, we can see that explosions become the most prevalent mechanism of lesions, notably because of the massive use of improvised explosive devices. So the particularity that soldiers also wear protective effects, helmet, goggle, and vest, and these protective effects offer a good protection against bullets, but there are frayed zones in the neck, in the axillary area, and in the lower back, as you can see on the picture. And we also know that facing an explosion, these protective effects offer a good protection against fragments, but a poor protection against blast or against over-pressurized lesions. So let's have a look at the prognosis according to the area injured. And this is a series of UK, about 3,000 soldiers injured in Iraq or Afghanistan. And first, the distribution is 1/3 for head, face, and neck, 1/3 for the trunk, and 1/3 for the periphery. And when we look at the survival rate, we can see that neck, head, neck, and thorax are the three areas with the poorest survival rate. So these areas are particularly challenging, okay? So let's talk about penetrating injuries by bullets. So war weapons are able to shoot bullets with high velocity. High velocity means high energy, and they can also shoot with high frequency, and this increases the lesional power of such war weapons. So high energy, high velocity, high energy, and high frequency increases the lesional power of such weapons. The bullets also in military on the battlefield are full metal jacket, and that give them the power to pass through the body from part to part, whereas in the civilian area, the bullets are soft, the head of the bullet is soft, and there is a deformation, such as a mushroom, and this deformation slow the bullet in the target and deliver a maximum energy in the first centimeters of the trajectory. Behind the target point in a gelatin block model, so you can see that there is a big deformation, and that a maximum of energy is delivered in the first centimeters of the target. And schematically, there is the wound is composed of a neck with
Oh, have we lost connection?
I think we. Okay. Oh, I think Dr. Boutonnier is back. Dr. Boutonnier, are you back? I can certainly see the photo.
I do not hope he has sustained a blast injury.
He's...
Can you see my screen?
Yes, we can. We can see them.
And can you hear me?
We can hear you very well. Thank you.
Okay, so thank you very much. Excuse me, my connection was quite unstable. So here, schematically, the ballistic profile after a gunshot injury. There are myths that we have to fight against. First myth: there is no sterilization by the temperature, and the wounds are always contaminated, and we have to administer prophylactic antibiotic therapy to the patients because infection is responsible for delayed avoidable mortality. And the surgeon have to be very prudent when they perform debridement. They do not have to perform debridement in the temporary cavity, but only the debridement of the destroyed tissue. Some words of terminal ballistic. And also like on the right of the slide, and so everything can happen. So we do remind that we have to treat wound, not to treat weapon. That's the main message. So explosion injury now. Explosion is a rapid transformation of a liquid or a solid in a gas, and that deliver high energy in a very short time and produces gas with high temperature and high pressure, and there is a blast wave that will issue from the explosion, and that will run around in the environment and can hit and produce lesions on the body. So the primary injuries are due to the shock wave. The secondary injuries that are the main injuries that we can see after an explosion are due to projectiles and to the penetration of these projectiles into the body. The tertiary injuries are due to the projection of the patients into the environment with contusion or fracture or and so on. And the quaternary injuries are due to high temperature and typically burn lesion. So the blast injury, the primary injuries, what is the message? The message is that the gas-filled organs are the most sensitive to the blast injury, to these overpressurizations, and here the tympan is the first organ that will be injured, but the message is that we do not have to use otoscopy to eliminate blasts because there are many false negatives. There are many patients, 1/3 of patients can present blast lesions and intact tympans. So do not use otoscopy to eliminate blast injuries. The other organ are the thorax, pulmonary, and visceral lesions. The specificity of the visceral lesion is that they can give delayed perforation lesions. Some case in the literature report delayed perforations about 10 or 14 days after the explosion. And the other message is that solid organs, just like cerebrum or osseous, orthopedic, are also sensitive to explosion, and typically amputations can occur and are responsible for hemorrhagic shock. And this is what we have to deal with. So the multiple fragment injuries are the main cause of lesion, because you have to be very close to the bone to suffer from blast injuries. The main lesions that we will see is multiple fragment injuries. These multiple fragment injuries will represent so many wounds with specific ballistic compartment, so everything can be seen, and the message is to treat the wound and not treat the weapon, and we have to focus on controlling the hemorrhage, to stop the blade and secure the airway, and evacuate the pneumothorax with the thoracostomy. So the pre-hospital management is based on standardized procedures with the aim to save life and to go fast. And typically the CABCDE protocol can be used very usefully. And hospital management, I will be very, very short, is based on damage control procedures. So damage control resuscitations aims at performing precoce and high ratio transfusion procedures using whole blood if you can. Realize permissive hypotension, prevent hypothermia, and use tranexamic acid as a procoagulant agent. Damage control surgery is also a strategy that aims at realizing hemostasis in a first surgical time. Then the patients return to the ICU, and he will benefit from other procedures in a few days or the day after, in order to reestablish the anatomy later once he is stabilized. Thank you for your attention. I hope you could copy me, and thank you for your attention.
Thank you, Professor Boutonnier, for a very clear and very educational session on the complexity of penetration and blast injuries. I've kept an eye on the Q&A box, and at the moment there are no questions from the audience, so I think we should continue with the third speaker. Thank you, Professor Boutonnier.
Thank you.
Thanks a lot for that excellent overview. It's my pleasure now to introduce Dr. Andrew MacDonald Johnston. Dr. Johnston is an intensivist at the Royal Centre for Defence Medicine in the Queen Elizabeth Hospital in Birmingham. He's experienced in managing large numbers of critically ill injured patients, both in Afghanistan as well as following repatriation to the UK. And also he's member of the UK Military Faculty of Counter-Chemical Biological Radiological and Nuclear Medicine. Dr. Johnston will talk about from chemical to nuclear threats. Dr. Johnston, please.
Thank you. Can I just make sure that you can see my screen and hear me?
We hear you.
Okay, and you can see my pictures, I hope?
Not yet.
Oh, right, hang on.
We are viewing the screen.
How's that?
We saw the message. Yes, we see.
Okay, so yes. I don't have any conflicts of interest. These are my own opinions rather than those of the UK military. What I'm going to talk about is some of the chemical warfare agents that have been used in the Middle East and elsewhere recently, including chlorine gas, mustard agent, and the nerve agent sarin. I will also briefly cover biological, radiological, and nuclear weapons. And my plan is to give you an overview of the kind of military agents that we worry about when planning for the critical care response to wars. I will link to various relevant articles via Twitter using the ESICM Alives Solidarity hashtag. The computed tomographic image shows typical appearances of blast lung injury, and we need to remember that if chemical or radiologic weapons are used, they are likely to be used with conventional explosives, and patients may therefore present with any combination of blast injury, burns, amputations, penetrating trauma from fragments or gunshot wounds, as well as additional injuries from chemical or radiologic weapons. If you have to treat patients injured in a chemical attack, you may have to use clinical symptoms and signs, the toxidrome of the agent, to identify what kind of attack it has been. If you are fortunate, you may have confirmatory information from the emergency services on the scene. Specialist teams will have access to mass spectrometry and other sensors that may identify the chemical involved. For most agents, management is supportive, although there are specific antidotes against nerve agents, cyanide, and lewisite. The specific response depends on the agent suspected. Many European countries' emergency services have well-practiced drills for dealing with chemical agents with specialized teams in place, and they are used to dealing with industrial accidents involving hazardous materials, so are well-trained and at high readiness, and they typically work well with the police and fire services. Before patients are brought to hospital, they should be decontaminated. This is a key step to prevent your emergency department, wards, or intensive care unit becoming contaminated with the associated risk of harm to hospital staff. The image shows a simulated chemical casualty being decontaminated, the first stage being cutting them out of their clothing, with rapid evacuation from the hot zone where they've been exposed, with only key life-saving interventions such as control of catastrophic hemorrhage and antidote administration performed while still in the hot zone. Once the patient is decontaminated, they should have prompt emergency medical treatment and medical review prior to evacuation to hospital for advanced medical care. I'll now talk about some specific agents. Chlorine gas was used extensively in the First World War, but was responsible for relatively few fatalities. It is not on the list of banned chemicals as it has multiple industrial uses in peacetime. In recent years, chlorine has been used by insurgent groups in Iraq, where industrial chlorine cylinders have been blown up in attacks on the civilian population, and has also been used in Syria. Most of the published work on chlorine exposure is from industrial accidents. Chlorine has a characteristic yellow color and a smell that is familiar to all of us. It causes eye and respiratory irritation at low concentrations. Unlike highly soluble gases such as ammonia, which dissolve out in the upper airways, the low water solubility of chlorine means it reaches the alveoli, where it forms hydrochloric and hypochlorous acid. It is then able to cause extensive lung damage. Symptoms include breathlessness, chest pain, cough, eye irritation, tachypnea, and wheeze. Chest X-ray may be normal or may show pulmonary edema without cardiomegaly. Management is supportive. Animal models suggest that corticosteroids may reduce the lung injury, but these studies are usually small and overall probably inconclusive. There are a very large number of other toxic industrial chemicals that may be released due to collateral damage to industrial facilities during warfare, due to deliberate targeting of such facilities, or due to purposeful release of chemical agents such as chlorine, hydrogen cyanide, phosgene, or other compounds. The next chemical agent I will cover is mustard agent. There used to be a lot of mustard agent in US and Russian repositories, but it is believed to have been mostly or completely destroyed. However, legacy artillery shells are still found in some parts of the world, and the agent itself might still be used in warfare. The dramatic blistering caused by mustard exposure is shown here. The agent is fixed within the skin within 2 minutes or so of exposure, then blisters develop some hours later. Symptoms are dose-dependent, ranging from mild irritation and erythema to severe full-thickness skin burns. The symptoms and signs may be delayed depending on dose. In more severe exposure, multiple small blisters form and coalesce to form large blisters. Management of patients with extensive exposure is similar to that of thermal burns. Mustard may also cause significant lung injuries, and extensive mustard agent exposure may require critical care support and wound debridement and skin grafting. Respiratory exposure is reported to cause long-term morbidity. Next, nerve agents. Nerve agents have been used extensively in Syria in the last few years. They typically have a very clear toxidrome, including pupillary constriction, muscarinic effects such as copious salivation, sweating, foaming at the mouth, respiratory secretions, and lacrimation. Patients also develop chest tightness, bronchospasm, marked bradycardia, abdominal cramps, and diarrhea. Nicotinic effects such as prolonged, widespread fasciculation of muscles progress to respiratory muscle paralysis and death. CNS effects range from CNS disturbance to seizures. The exact toxidrome and speed of onset is dependent on the specific nerve agent and the route of exposure. Exposure to volatile nerve agents such as sarin cause rapid pupillary effects and rapid onset of systemic poisoning via inhalation. Persistent or artificially thickened agents such as VX or Soman, or the newer agent Novichok, may have a slower onset and possibly an atypical or delayed toxidrome, particularly if they are absorbed through the skin. Management of nerve agent poisoning involves decontamination by removal of clothing. This will remove about 90% of the agent. Administration of an oxime to reactivate the patient's acetylcholinesterase should be done as soon as possible before the nerve agent binding to the enzyme becomes irreversible. Administration of atropine counters the muscarinic effects of the agent with repeated administration until the heart rate rises above 90 beats per minute and secretions dry up. Doses of atropine needed may be more than 10 to 20 milligrams in the first few hours after exposure, with patients potentially requiring 50 milligrams of atropine in the first 24 hours. Atropine may have no effect on pupillary constriction if the patient has been exposed to a volatile agent, so other markers of response such as heart rate and cessation of sweating and secretions are more useful. Patients may require benzodiazepines for the central nervous system effects of nerve agent, which are seizures and confusion. In terrorist or military use of nerve agent, there is convincing evidence that oxime antidotes are effective, unlike in organophosphorus insecticide poisoning, where they are probably not effective. And of course, patients who have severe nerve agent poisoning may require respiratory support on the critical care unit, and in the case of persistent agents, may have a prolonged intensive care stay. Here is an example of tongue fasciculation from a New England Journal case report reproduced with permission. The finding of widespread fasciculation of tongue and other muscles is a key part of the nerve agent toxidrome and is not seen in many other conditions. I'll talk a bit more about decontamination. So initial decontamination of patients exposed to chemical agents should be by removal of clothing. There is good evidence that this will remove 90% or more of the agent. Then wet decontamination should be used. Wet decontamination is the standard system and utilizes water, usually in the form of showering facilities. The addition of dilute household bleach, 0.5% sodium hypochlorite, is used by military decontaminations. Medical decontamination typically uses warm soapy water, and this will remove the vast majority of chemical agents. The soap or bleach in the decontamination fluid will also degrade most or many chemical and biological agents. I'll talk briefly about biological agents. These may take the form of microorganisms such as viruses, Ebola, smallpox, and others, or bacteria. Bacteria that might be used include unusual diseases such as anthrax, pictured above, or tularemia. These may be modified to be antibiotic resistant or may be more virulent than expected with rapid onset of sepsis. Finding patients with a disease that is unusual in your geographical area or an outbreak of something that is recognized as a potential bioweapon, such as smallpox, should raise suspicion of the deliberate release of a biological agent. There are also numerous biologically derived toxins, such as ricin, which causes a SIRS-like syndrome culminating in death, botulinum toxin, which causes paralysis, or various staphylococcal toxins or fungal toxins. For the live biological agents, treatment is as for other infectious diseases, but with a high suspicion that they may be antibiotic resistant. For the toxins, treatment is usually supportive, although there is a specific botulinum antitoxin available. There is the possibility of the use of radiologic exposure devices, which is the use of unshielded radiological sources to expose individuals or a large number of people passing the site where the device is left. However, this seems relatively unlikely in the context of a war. Radiologic dispersal devices are explosives attached to radioactive isotopes, essentially an improvised bomb used to disperse a highly radioactive substance. The biggest risk from these is expected to be conventional ballistic injuries from the explosive blast and associated fragments. The casualties may have surface contamination with radioactive material or may have radioactive material in their wounds. This is easy to detect with radiation detectors, and most contamination can be easily identified and removed with conventional decontamination. The area where the device has exploded may be heavily contaminated and may require a prolonged and extremely expensive cleanup. The risk of serious radiation poisoning in casualties from these devices is likely to be low. In the event of deliberate or collateral damage to a nuclear reactor, there is a risk of significant radiation exposure to a large number of people, potentially similar to the Chernobyl reactor accident. Much of this is likely to be long-term risk over a period of many years, but there is a risk of significant radiation exposure to first responders at the scene, possibly in combination with thermal burns, blast, or penetrating injuries from explosives. There is a large amount of theoretical work on whether treatment modalities such as bone marrow transplantation might be effective for patients with significant radiation poisoning. Clearly, this depends on just how many patients there are, whether they have surviving relatives who can be screened as bone marrow donors, and the capacity of the local or wider European healthcare services to accommodate them alongside other demands related to ongoing refugee and combat trauma patient numbers. Nuclear explosions. In a relatively small tactical nuclear bomb explosion of 10 kilotons in a city, we could expect 100,000 deaths immediately and 100,000 casualties. In this scenario, there is no realistic role for critical care. Patients will have a combination of burns, radiation poisoning, and blast or fragment injury. Data from the Second World War and from subsequent animal work suggests that the combination of conventional and radiation injury is more lethal than either alone. There is a strong likelihood that any medical facilities and medical providers in the area will be dead or injured. In larger strategic nuclear explosions, potentially including nuclear war, again, there is no realistic role for critical care. My last slide, there is a UK National Health Service Emergency Preparedness, Resilience and Response Aid memoir available online, which provides advice on the management of unfamiliar injuries, including injuries from weapons of war. It is designed to be used at the time of injury and is freely available online. I will tweet the link. And that is me finished. I'll be very happy to take any questions.
Thank you, Dr. Johnson, for that overview. I was wondering, to your knowledge, are there any thoughts or suspicions of any biological currently being used in Ukraine?
I'm not aware of any biological weapons being used. Obviously, there are rumors about lots of different weapons. We have to be very careful not to be taken in by propaganda about weapons being used without any evidence of that being the case.
Mm-hmm. Yes, I understand that. You talked about the decontamination, and as we heard from Dr. Pilipenko, there are civilians bringing the patients to the hospital. Do you think they should mind this to decontaminate themselves, or is there any danger there, an additional danger?
So in the past, when there have been terrorist attacks using chemical weapons, patients have come into hospitals without being decontaminated, and some of the hospital staff have been affected. That happened in the Japanese Tokyo subway attacks. So you have to have a high index of suspicion for chemical agents being used, and if there is evidence that they're being used, patients should not be allowed into the hospital until they have been decontaminated.
Okay, that's a very clear message, I think. How are we in terms of time, Marlies?
I'm afraid we've reached the end of this session. I'm sure we could go on for longer because there's so much to learn, as I've just realized. But we have reached the end, and in respect really of the next presentations, we have to finish. And this concludes this session. I would like to thank all three speakers for fantastic presentations. You clearly outlined the challenges of practicing critical care during war times, but you've also shown the sacrifices healthcare professionals make during these times in Ukraine, but in other disaster zones where they show resilience and risk their own life in order to save others. Thank you for highlighting and showing this so successfully. On behalf of the ESICM, I would like to thank you and express my solidarity and support. Thank you.
Thank you very much.
Bye-bye.
Good afternoon. Welcome to part 3 of this Solidarity Marathon. This session is entitled Critical Care Illness in Migrants and Refugees. My name is Carol Belanger. I'm a consultant nurse from Exeter in the UK, and I'm delighted to be co-moderating with Professor Margaret Herridge from Canada. We've got three excellent talks for you this afternoon, and I think we'll start straight away with Dr. Sami Rayesh, who's an intensivist from Marseille in France, who's going to be talking to us about the size of the problem. Thank you, Sami.
Thank you very much. Dear colleagues, first of all, I would like to thank the ESICM Scientific Committee for this initiative and also for this invitation. It's a great pleasure for me to talk about this very interesting topic. And in the few following minutes, I will try to give you some elements to answer to this question concerning critical care illness in migrants and refugees, and what is the size of the problem. So to begin, sorry. Some elements of context. So what has been called migrant crisis in the last few years represents 281 million of people in the world in 2020. And this is an increase of about 60 million as compared to 2010. In Europe, the same year, there were 2.6 million refugees and almost 500,000 of asylum seekers. And more recently, more than 3 million of Ukrainian people have become refugees because of war. So, of course, this represents a huge public healthcare challenge. But what is really known about migrants' health? What is commonly reported is that migrants are younger and healthier than a general population in destination countries. And therefore, they might have a mortality advantage in main diseases apart from traumatology and infections. This has been very nicely shown in this review published some years ago by Aldridge and colleagues. But it was also reported in other papers, and it has been called the healthy migrants hypothesis. However, when doing the literature, it's glaring that data are missing concerning the most precarious people, and especially undocumented migrants, refugees, asylum seekers. Because of their clandestinity, they are very difficult to know, to have data about them in the published literature, and even more concerning critical illness. So is that to say that migrants are not concerned by critical illness because they are healthy and young? And can we say that it's not really a problem? This would be very surprising because migrants, especially undocumented migrants, share several conditions that expose them to a critical illness. First, when especially coming from low-income countries, the lack of preventive medicine in their origin countries expose them to an increased risk of chronic diseases, vaccine preventable diseases, and also obstetrical emergencies. Second, the high prevalence of infectious diseases such as HIV, tuberculosis, hepatitis, or other tropical infections are also a risk factor for critical illness. And lastly, when they arrive in destination countries, and especially in Western countries, they often encounter several barriers to primary health care, which could represent a delay to access to treatments. And it has been reported a frequent recourse to emergency wards and a potentially increased severity of the disease at the arrival to the hospital. So, elementary data are unknown, missing concerning undocumented migrants entering the ICU, especially, apart from reports from trauma and victims of war. And these elements are essential to provide effective, efficient healthcare to this population. The main questions that we can ask is, who are the migrants entering the ICU? How many are they? Why are they admitted to the ICU? And lastly, what kind of treatments do they need, and what is their prognosis after being discharged from the ICU? So we tried to answer to these questions in a lastly published work, focusing on undocumented migrants, which was fully done previously, admitted to French intensive care units from 2011 to 2018. We made a retrospective cohort study based on the National Register. And in this work, undocumented migrants were very difficult to identify, but we found an indirect mean to identify them based on the coverage by either of one of the systems for specifically for undocumented residents. In France, urgent care and state medical aid are devices that allow to provide free healthcare to undocumented people according to the French law. So this is how we identified in this register undocumented migrants. We collected data concerning demography, the reason for ICU admission, the invasive support required, and also costs, and finally the prognosis. Migrants were compared to general population in a first accrued analysis and then in a matched analysis, and we matched migrants to patients from general population based on age, sex, SAPS2 score at ICU admission, comorbidities, and reason for ICU admission. So let's see some results of this work. The first information we found is that the number of undocumented migrants admitted to a French ICU during the period has more than doubled from 2011 to 2018. The number of migrants ICU stays represented 2 per 1,000 of the total number of ICU stays in 2011, and 7 years later, this number represented 4 per 1,000 of the total of ICU stay. And the number of ICU admission is increased faster in the migrant population than in the general population. This increase was correlated with the increase of the number of asylum seekers and refugees in France in the study period. So if we want to have an insight to know where did the migrant admitted to the ICU came from during this study period, we can rely on the data from the French Office for the Protection of Refugees and Stateless Persons. And we can see that the main origin countries are Africa, Northern and Central Africa, but also Syria, especially in the year 2015, after the civilian war, and also more recently Eastern Europe, such as Albania or Afghanistan. Of course, this was done before the Ukrainian war. We also tried to know where these migrants were hospitalized, and it's not a surprise to see that the Parisian area was far ahead, followed by southern region around the Mediterranean Sea. Some elements about the whole population. As you can see, the cohort of migrants represented more than 40,000 people during this 7-year study. We found that migrants were younger when admitted to the ICU than general population. The mean age was 47 as compared to 64 for general population. They had less chronic heart or respiratory or kidney disease or cancer than general population, but there was a difference also on severity at ICU admission, and we found that migrants had a higher SAPS2 score at ICU admission when excluding the points of age. less chronic heart, respiratory, kidney disease, and cancer, but specific comorbidities. Unsurprisingly, chronic liver disease were more frequently retrieved in migrants, but also tuberculosis and HIV. And also, there was a higher report of alcohol and drug abuse among migrants, which is questioning about their mental health. We then focused on the reason for ICU admission. The main three reasons for ICU admission for migrants were shock, trauma, and postoperative care. But when we adjusted on age and sex, we found that migrants had a higher risk than general population to be admitted to the ICU for obstetrical complication, infection, and mainly severe infection, as shown by the higher number of shock and septic shock than in general population after adjusting on age and sex, higher risk to be admitted for coma, acute kidney injury, and acute respiratory failure. After they had been admitted to the ICU, we wanted to know what was the intensity of care that they needed. And we found that the life support provided in the ICU, after matching the cohort, was a higher recourse to high-flow oxygen, to invasive mechanical ventilation, to catecholamines, renal replacement therapy, and blood transfusion in migrant population as compared to general population. And also, we found that palliative care was more frequent among migrants than in general population, which is rather an intriguing result. Lastly, concerning outcomes, when considering the whole population, migrants' mortality was lower than in general population, which was of course due to their younger age. And after adjustment, migrant and general population mortality was comparable and rather low in our series. But even after adjustment, migrants had a longer duration of ICU and hospital stay, probably because of the absence of residents. And the higher intensity of care that they needed during the ICU stay and the prolonged ICU and hospital stay were responsible of increased costs that probably might have been avoidable. So to conclude, we found that nearly 3,000 undocumented migrants are admitted to the ICU each year in France, which is quite a high number. And it is probable that the case of France is not isolated and that maybe this number would have been higher in other countries, such as Germany, UK, or Southern Europe countries. And this phenomenon is probably going to increase with the recent Ukrainian war. Migrants admitted to the ICU appear to be young people, and they are also have a severe presentation with more frequent shock and septic shock, obstetrical complications, coma, acute kidney injury, and acute respiratory failure. When admitted to the ICU, it appears that migrants require more frequently very invasive care, which could be due to a more severe presentation because of delayed treatment and maybe barriers to access to primary health care. And when admitted to the hospital, they stay longer. So it seems urgent to evaluate the problem at a larger size in a European prospective study, to go deeper inside in a medical presentation, but also in more sensitive problems such as communication and ethics and problems of end of life. Thank you very much for your attention.
Thank you very much, Sami. Do we have any questions? I'd like to ask you one, Sami, if that's okay. It looks like the migrants may be presenting much later, which has an impact on their duration of stay and their acuity in the ICU. how does that translate when they're discharged? And is that a significant issue when they're discharged out into ward areas? And what sort of sequelae can we see from that? Is that data that we're collecting yet? Do we see lots of readmissions of migrant patients because of all those issues you described that lead them to intensive care in the first place?
If I understood well, your question is about readmission after ICU discharge, is it? Okay, we focused on the readmission during the year following the ICU discharge, and we found that these people, this population of patients, migrants, had an important risk of readmission in the year following the ICU discharge. And this risk was higher significantly as compared to general population, probably because of the absence of follow-up of a regular consultation in primary healthcare, and this is in line with the fact that they need a better follow-up after ICU discharge.
Thank you very much, Sami.
Pleasure.
There's no questions on the chat at the moment. Shall we move on in the interest of time?
Yeah. Sure. It's my pleasure to introduce our next speaker, Dr. Jose Garnacho Montero. Dr. Garnacho Montero has a very distinguished career and currently is the chair of the intensive care unit in the Hospital Virgin Macarena in Seville. He's served extensively at the ESICM with great distinction. And it's my pleasure to introduce him now to speak to us about the infectious challenges. Welcome, Dr. Garnacho Montero. Thank you.
Thank you, Margaret. It's a pleasure for me to be here in this interesting initiative. And of course, I'd like to give my congratulations to the leaders of this initiative, to Dr. Ciaconi and Dr. Elia Sulai. My task today is to talk about the infections, the severe infection, as reason for admission in the intensive care unit of refugees and migrants. Everybody knows that we are in a health crisis since the invasion of Ukraine by the Russian Federation on 24th February 2022, and in just a month, more than 4 million refugees have been forced to flee to the surrounding countries. But we also have the problem that more than 6.5 million people have been displaced internally within the Ukraine. A great number of them are children. And of course, this is a humanitarian crisis not seen probably since the Second World War. These are the numbers that I could check last Monday, and as you can see, more than 2,300,000 people have fled to Poland, especially to Poland and to Romania, and the cumulative data in that day of March 28th is almost 4 million people had fled to the neighboring country, fleeing from the war, from this terrible war. This is the study that my previous speaker spoke, Dr. Sami Hartway. He's the first author, and I'm not going to explain the manuscript that was released a few weeks ago because he has done his talk. But just to mention that this is probably the most recent study and with more compelling data. And as he mentioned before, we have to highlight that the number of undocumented migrants admitted to the French ICU has doubled in the study period from 2% to 2 per 1,000 to 4 per 1,000. I use this slide because this slide was also, or this cartoon was also used by the previous speaker, just to certify that after adjustment, as he explained, infection is the second most frequent cause of ICU admission among migrants in this French experience. And of course, as you can see, skin and soft tissue infection, skin and soft tissue, many of them are infection, as well as shock, and the third and the fourth more frequent reason for admission, indicating that infection, in this case severe infection, is a very serious problem in refugees and in migrants. This is the experience published from Turkey a few years ago, analyzing people, refugees, people admitted to the ICU for community-acquired infection. And as you can see, as expected, pneumonia was the first cause of admission, followed by UTI and skin and soft tissue infection. And as you can see in the right part of the slide, it is very interesting because when we check for the pathogen involved in pneumonia, Mycobacterium tuberculosis was the most frequently isolated pathogen, and this is an issue that I will insist later on. Many factors explain that infection are one of the more frequent reasons, or probably the most frequent reason, with the exception of obstetric causes of ICU admission for migrants and refugees. Obviously, this can be explained by many factors that we all have in mind, and I have tried to summarize in this slide. Of course, many of them has this infection previously, but factors associated from the situation of migrants and refugees, like overcrowding, inadequate shelter, malnutrition, the use of undrinkable water, adverse climatic condition, the exhaustive physical exercise that these people have to do to flee from the war or flee from any adverse situation, insects, trauma, and of course in the war, pues we cannot forget war wounds. All of these make a cocktail that explain why infection is one of the most frequent, or probably the most frequent cause, perhaps avoiding trauma in the worst scenario for admission to the ICU. We cannot forget that we are dismayed by the situation of the country of Ukraine, but we cannot forget that many other countries are unfortunately there are still active conflicts that explain that the situation is not restricted to Ukraine, and this situation of war and people fleeing from the war occurs right now in many other countries in Africa or in Asia, and this is what I would like to represent with this slide and the picture. This is a review published 4 years ago in Intensive Care Uni by Dr. Garifalia. As you can see in this slide, obviously the infection that we can see in the migrants or in the refugees depends on the area, on the geographic area where the conflict occurs. As you can see, of course, the infection differs. If the infections differ, if the situation occurs in Africa, where the problem of malaria or the problem of certain viruses, especially hemorrhagic fever, is a main problem, differ from America, or the case of Europe and Asia, where different pathogens are involved, pathogens that include bacteria, viruses, or protozoa. The main infection critical syndrome with potential to cause ICU admission as probably as occur in the rest of patients admitted to the ICU. The first cause can be respiratory insufficiency, followed by sepsis or septic shock, multi-organ failure, and in other cases, neurological syndrome or the throatic disturbance or the hemorrhagic fever are the reason, the syndromic reason for admission. But if we focus on community-acquired infections, probably the first focus of community-acquired infection is respiratory infection that can be caused by bacteria, by viruses, including SARS-CoV-2, COVID-19, and of course tuberculosis, and I will insist later on. Food infection, gastrointestinal infection, especially with enteric fever or cholera, skin and soft tissue infection. I will review in the next slide, central nervous system infection with bacterial and viral encephalitis depending on the area. It's a West Nile fever is a problem worldwide. Malaria, especially in Sub-Saharan Africa. Visceral dysmenorrhea or the hemorrhagic fever, not restricted to Africa, but especially it's a problem in Africa. Concerning the severe skin tissue infections, bacterial skin infection are the more common, and the pathogen involved are the same pathogen involved in any skin and soft tissue infection, especially gram-positive bacteria, although gram-negative and anaerobic bacteria can be also involved. But we cannot forget in certain epidemiological situation the role of Canusiform canemosus in the case of a dog bite, or certain soft tissue infection associated with water, like Vibrio or with Mycobacterium marino. Of course, in other areas, don't forget malaria. It can cause admission to the ICU or the protozoa schistosomiasis, and many of the patients are admitted to the ICU for healthcare-associated infection. The majority of them, but not all of them, are related to surgical procedures, and in this case, the nosocomial infection can be caused by a multi-drug resistant pathogen, and especially gram-negative bacilli, and I will discuss later on. But focusing my talk on the current health crisis in where people are fleeing to the surrounding countries like Poland, Slovakia, Hungary, or Romania. In this case, communitary infection are the same infection as I explained before. I will discuss in the next slide the problem with COVID-19 and multi-drug resistant tuberculosis, and of course we cannot forget the common pathogen involving this infection everywhere all over the world. The problem of COVID-19 has not finished in the world. I think that we cannot say that the pandemic has finished, although the numbers or the figures are better right now. But in the case of Ukraine, the problem is that only 34.5% of the population is fully vaccinated. It means that 2/3 of the population is not vaccinated, that there was a surge in cases due to the Omicron variant in the first week of February in Ukraine. Now, these weeks, we don't have number for evident reasons, and this explains that this explains why many people fleeing from Ukraine may have COVID-19, and the overcrowded situation can, of course, facilitate the spreading of these viruses. So don't forget COVID-19 as a possible pathogen involved in infection syndrome with fever or respiratory insufficiency in people from Ukraine. And the problem of multi-drug resistant and extremely drug-resistant tuberculosis is a serious concern in Ukraine, and you can see here more than 6,500 laboratory confirmed cases of multi-drug resistant cases of tuberculosis were declared in 2017, and this is, as you can see in the lower part of the slide, in the Ukrainian outbreak, this study published in Infectious Disease in 2020, all the isolated were resistant to isoniazid, rifampicin, streptomycin, and ethambutol, making this a very serious a real threat of public health. This is another example of this study analyzing the situation in Europe and Central Asia about tuberculosis, and the number of multi-drug resistant tuberculosis was increasing in these 8 countries that includes Russia Federation and Ukraine. Of course, we can have many patients admitted to critical care units after wounds or after surgery for wounds or for other situations related to violence. And in these cases, surgical site of infection and wound infection are obviously the main causes of infection in this patient, although we cannot forget Brunstein infection or pneumonia as in any critical ill patient. And the problem with the drug-resistant pathogen is very serious in Ukraine, as you can see in this slide. These data are from the ECDC in the period 2016 to 2020. And as you can see here, the rate of E. coli resistant to carbapenem is high, 4.4. It's very high compared to other countries. But in the case of pneumonia, or Klebsiella pneumonia, more than 50%, 53%. In the case of Pseudomonas, 70% are resistant to carbapenem. And as you can see, Pseudomonas, more than 50% are resistant to piperacillin tazobactam or to ceftazidime. Acinetobacter, almost 90%. Anyway, it's a very, very serious situation because the resistance to conventional antibiotics is extremely very high in this region of Ukraine. You can see the same information in this slide, the number of Pseudomonas resinosa resistant to carbapenem, more than 50%, or Klebsiella pneumonia, more than 50%. And the rate for penicillin-resistant Staph aureus is lower and very similar to other European countries, and it's 18.8%. Of course, we cannot forget Acinetobacter. We read many papers describing the situation of the Iraq and Afghanistan war with many outbreaks of Acinetobacter, Boutonnier infection, food infection, and other infections in injured soldiers and in injured people in this war. And the same has been it's occurring in Ukraine. And the other problem is the dissemination of resistance mechanisms with these people that are fleeing from this area to other parts of Europe. This is a case that describes the isolation of Enterobacter cloacae, MDM1, it's a metallobeta-lactamase, or AMC that was transferred from Ukraine to Spain, and in my country, the patient was transferred from Ukraine to Malaga 3 years ago, and this is the first report case in Europe or with E. coli with these two mechanisms of resistance for Enterobacter cloacae. Of course, this explains and this justifies that we should recommend a screening of multi-drug resistant pathogen at ICU admission and preemptive isolation. Of course, the management of this patient is complex, especially if tropical infections are involved. So this is the approach with a multidisciplinary team with intensivists, especially in infectious disease, especially in tropical medicine, microbiology, pharmacy, and public health department. And just to finish, my take-home messages are that sepsis and severe infection are one of the main causes of ICU admission for refugees and for migrants. A multidisciplinary approach is recommended, especially if tropical infection disease may be implicated. We should know the ecology of the country, that it will be of great aid for the election on empirical antimicrobial therapy in order to choose the most adequate antimicrobials. Don't forget multi-drug resistant tuberculosis in Ukraine. Don't forget COVID-19. And my recommendation, whenever possible, is to screen for multi-drug resistant pathogen in all patients admitted to the ICU. Just my last slide is that this is a project from the Spanish Society of Intensive Care, ICU Without Borders, that has been launched very recently. And this is a collaborative project with a hospital in Africa. And as you can see, this was launched very recently. And we are really very interested in this initiative, because I think that this collaboration will be of great aid for our college, for the people in Africa. Thank you very much for your attention.
Thank you so much, Dr. Garnacho Montero, for an outstanding talk. It was really so informative. I don't see any questions on the chat. Maybe we have time for one quick question, and I'm happy to maybe ask this of you. There's certainly a lot of implications in terms of having patients who have multiply drug-resistant organisms coming into the ICU in the community. And this changes a lot of empiricism and also the whole microbiome of the unit and the patient population that's there. Maybe if you can comment on the implications of that a bit, and also related to Dr. Rayesh's and Dr. Boulanger's question from the earlier discussion. There are huge implications here in terms of follow-up and subsequent care, and really trying to address things like MDR, TB, HIV, et cetera. So maybe 2 parts to that. Thank you.
Yes, of course. I think that is, of course, our main task as intensive is to save our patient lives. But we cannot forget that to save this life, we have to, if the patient has an infection, we have to use the more adequate antibiotic, and we have to know the pathogen likely involved in this infection. It can be a pneumonia, or it can be a wound infection. The second part is to protect the other patients, because if one of these patients is transferred to an ICU abroad, Ukraine, and the patient is in any of the surrounding country, or the patient is transferred to, some patient has been transferred to other countries in France or in Spain, of course we have to hold the dissemination of multi-drug resistant pathogens. When I heard the previous speaker telling us its experience in a hospital in Ukraine, of course it's very difficult to isolate a patient in Ukraine to avoid dissemination of multi-drug resistant gram-negative bacilli or multi-drug resistant pathogen. But if this patient is transferred to another ICU, just in any country, I think that these 2 measures have to be ordered in order to avoid the dissemination. Is the admission, the isolation, preemptive isolation, and of course the screening for the harboring multi-drug resistant gram-negative bacilli.
May I add some comments, Dr. Harwich? First, I want to thank Dr. Garnacho Montero for this very interesting and brilliant presentation. In the last few years, in the ICU where I'm working, we had several patients coming from Eastern Europe and suffering from severe and multi-drug resistant tuberculosis. And finally, they died in the ICU with extensively drug-resistant tuberculosis. And one of the factors that was determinant is that these patients didn't have a follow-up, and they had antibiotics, then they stopped, then they had again, and they developed resistance because of this exposure to antibiotics without any follow-up. And so what I want to say is that our work in the ICU, as Dr. Garnacho Montero said, is to save lives, but also what we do is nothing if the patient, after being discharged to the ICU, don't have a good social and also good follow-up with infectiologists. And so ICU cannot be isolated. It's a part of a larger chain of healthcare.
Thank you so much. Thanks again, Dr. Garnacho, and thanks, Dr. Rayesh, for those great comments. I'll turn it over to my co-chair now, Carol Boulanger, to introduce our final speaker. Thank you.
I'm unmuted. Can you hear me now? Okay, so it's my great pleasure to introduce Dr. Katarina Rusnova, who's a great supporter and very active in the society. She's the head of the Department of Palliative Care Medicine in Prague, and she's going to talk to us about a very important aspect of what we've been talking about this afternoon, which is the invisible wounds. Many thanks, Katarina.
Thank you for having me, and I would like to shift a little bit our focus from pathogens and diseases actually to the people. And this is my first slide. I would like to touch upon two recent topics. One of them would be the pandemic, and one of them, of course, would be the refugees crisis. And this won't be, my talk won't be about presenting you the data. I will try to reflect on 4 points. The first will be that we are all aware of the basic needs in terms of food, housing, and safety. And what I would like to do to add another basic need, which is being heard and understood. The second point I would like to reflect on would be the theme of resilience. And I would like to make a parallel between first-line responders and war refugees and what resilience means. And then talk a little bit, spend a little bit, a couple of minutes on hope, what hope is, why we need it, what kind of hope can we offer? And then lastly, I would touch upon uncertainty. So back to the first point, the basic need, being heard and understood. I think there are multiple challenges for us. And as we are facing a wave of refugees in my country, several hundreds of thousands, there is obviously language barrier and also the different alphabet. So on the right side of my screen, you can see the translation of the information for parents and their kids coming into our hospital and our maternity department. So this is the first thing to think about when we would like to achieve the goal for the refugees of being heard and understood. Not being heard and understood also means for the refugees limited possibility for sharing, which is the basic mechanism, basic coping mechanism for the crisis situation. And I mean in-depth sharing, that's one of the most helpful strategies to overcome crisis situation, and language barrier is a major barrier in this context. There are obviously cultural differences between the refugees and the general population of the respective country, and there are also generalizations and assumptions about refugees. I think this should be mentioned because generalizations might go toward lower competence or lower education, and this can be also a barrier for them to being heard and understood. So let's pay attention to these generalizations and assumptions that we can have. The second point of my reflection would be resilience. And as ICU clinicians, the population, our patients and families and our colleagues expect that the emotions in the ICU basically are taken aside and all the focus is on saving lives, which is a reasonable expectation, of course. And I think the same is expected from war refugees. They are putting all their energy to flee the country, and basically their emotions are also put aside. And all the emphasis is on performance. But let's don't forget the emotions, because unless we have resection, I mean neurosurgical resection of the limbic system, the emotions don't go away, cannot go away. And we need the limbic system to cope with the crisis and with all these emotions. We need amygdala, we need to to integrate the crisis and integrate the trauma, our orbitofrontal cortex, and in order to overcome the crisis situations, it means a lot of learning. It means building new synapses, speaking like from a neuroscience point of view. And this is a really big energy consumption. So let's don't forget about emotional regulation and its role in coping and overcoming crises. Because if these mechanisms and these coping mechanisms are insufficient, this is the highest cause, the biggest cause of risk for burnout, post-traumatic stress disease, and trauma. So I would like to advocate to be proactive. I would like to say it's almost our duty to prepare for that, because as we know, offering support to emotional well-being comes often late. So let's be proactive in emotional support for the clinicians and also for the refugees. My third point was to speak about a little bit hope. What hope is needed? Everybody needs hope, obviously. Can we offer hope as clinicians to the refugees? What kind of hope? When we're speaking about hope in the midst of crisis, it is normal to shift from unrealistic hopes to realistic hopes, and to switch from, all will be good, and strong hope, all will be good and quickly good, and the sense of despair. And this is a physiological adaptation process, and it needs time to build a more realistic point. And as clinicians speaking about hope, for us, it's mainly Kaplan-Meier's curve and median survival. But I would like to expand your vision on hope. And hope might be also seen as a psychology phenomenon. And we can foster the adaptive coping strategies. And there is also a third dimension of hope, which I call a spiritual dimension of hope. And that is when I hear my patients or the family members telling us, I feel it has some sense, even facing adversity, even facing negative prognosis and bad prognosis. They come to say, it makes sense for me. It's difficult, but I can cope with this. So there's also a spiritual dimension in hope. So let's expand our vision on hope, not only in terms of median survival, but in terms of coping and making sense of the situation of crisis. There are some useful tools to assess hopes and worries. And these are questions: what are you hoping for? The first answer to what are you hoping for is usually the unrealistic scenario. So I would suggest to ask again, what else are you hoping for, and what else? And to give a space for them to expand and to elaborate on the thinking about hopes, because in repeating these questions, we come to more realistic hopes. And also it's useful to ask about their worries. And hope cannot be prescribed like noradrenaline, of course. And the point is that physicians can have an essential role, not in increasing or maintaining or taking away, etc., but helping our patients and their families to work out hope. And the last point of my reflection would be a couple of words about uncertainty, because as we all know, this crisis will be a long run. When speaking about uncertainty, we could say it's a situation in which something is not known on a cognitive level. But I added that it also is an unstable feeling. So again, emotions. Unstable feeling we get when we step out of our comfort zone. So let's get ready for increased emotional exposure because we already have faced higher prevalence of feelings of helplessness. I mean, as clinicians, I was facing feeling of helplessness during the COVID crisis when taking care of unvaccinated patients or patients denying the COVID disease and COVID pneumonia. So let's get ready for that. It will be difficult, and also I would advocate for fighting the crisis fatigue. We need to better understand the pathophysiology, and let's acknowledge the role of emotions, because this will help us in designing intervention to support coping. So to summarize, I was trying to advocate for food, housing, safety as the basic needs, but let's add to this being heard and understood. Resilience is, I think, the antidote to burnout and trauma. Hope cannot be prescribed. It has to be worked out, and it's a process. So let's be patient, and it will be a long run. Thank you. That's all.
Thank you very much, Katarina, for an excellent talk. Oh, if we could prescribe hope, that would be amazing, wouldn't it? Do we have any questions from the floor or from the rest of the panel?
I'm happy to ask a question to Dr. Rusinova. I noticed from the data that Dr. Ryash and Dr. Garnacho Montero showed that the folks coming in, the refugees, had a high incidence already of alcohol use and drug misuse. And so this may be that they've already been in crisis, but it would seem to be a very important marker for mood disorders and for the vulnerability in this group for current mood disorders and an exacerbation of mood disorders. How can we sort of really take care of these folks and offer mental health supports to such a vulnerable and sort of transient group of patients and their families?
I think this question goes beyond the healthcare system. I think there's a larger responsibility, and I mean what we are experiencing here in my country, it's a larger solidarity phenomenon. So there are families taking the refugees, which are mainly women with their kids, into their homes. Then they are soon integrated into schools. And we have a few men refugees really right now because they all stayed in Ukraine. So I think the best treatment for drug abuse and prevention are good relationships. So early integrations into the society. So this question goes beyond the healthcare system. And I'm happy to say that the Czech Republic was known as refusing many of refugees from Syria. And we are quite in the reverse situations now, as many of the citizens of my country are welcoming in their home the refugees, and I'm happy to see this is really helpful, and they are able to act quickly. They are close to them, they know them, and so this would be my answer: treating mental health disorders also by relationships building.
Thanks so much for that, Dr. Rusinova. And I see that it's 11:20, and I wonder if we should just close our formal session now. Sorry, I'm in Canada, so it's 11:20 here in Toronto. If I'm confusing the audience, I'm sorry.
11:20 there.
But on behalf of my co-chair, Carol Boulanger, and myself, our sincere thanks to our wonderful speakers today, Sami Rayash, Jose Garnacho Montero, and Katerina Rusinova. Really a wonderful and informative session, and thanks to the ESICM for sponsoring such a worthwhile solidarity program. And we wish everyone a great day. Thank you.
Thank you.
Bye-bye.
Thank you very much.
Thank you very much.
Thank you.
My pleasure.
Welcome back at ESICM Alive Solidarity Marathon. We will continue with a session on the legacy of the last 2 years. My name is Margot van Mol and I work as a postdoc researcher in Erasmus MC, the Netherlands. My co-moderator for today is Adrian Wong. Please will you introduce yourself?
Hello everyone, good afternoon, good evening. My name is Dr. Adrian Wong. I'm a consultant at King's College Hospital in London. It's a delight to chair this session with Margot, and it's also an honor to introduce our first speaker. And she's Louise. Louise is a senior clinical researcher and member of the emerging infection groups at Oxford University Clinical Research Unit based in Ho Chi Minh City, Vietnam. Her work has focused on improving critical care of ill patients in resource-restricted settings. She's an associate professor in the Center of Tropical Medicine and Global Health at the University of Oxford. She's the Critical Care Asia ICU Network lead for guidelines and policies in the Asia-Pacific Sepsis Alliance. And Louise is going to share with us her thoughts entitled COVID-19 is Far From Over, LMIC Perspective. Over to you, Louise.
Thank you very much, Adrian. And it's a real pleasure to be able to speak to you all today. I'm going to be really giving my perspectives on the pandemic in Vietnam, but I think many of the issues are going to be common to low middle income countries, but perhaps more widely than that even. So Vietnam is a country in Southeast Asia, a population of about 100 million people. And I live and work in Ho Chi Minh City, which has got a population itself of about 10 million in the south of Vietnam. The pandemic in Vietnam is perhaps a little bit different to many countries, and given that Vietnam has a land border with China, we were quite concerned at the beginning of 2020. And indeed, one of the first cases reported outside China was somebody in Ho Chi Minh City in Vietnam. However, the country responded with a really strict lockdown and border closure. And essentially that did mean that the pandemic was very much controlled. And in the panel here on the right, I'm just trying to give you a kind of flavor of that, comparing with a European country, the UK. You can see that really the number of cases in orange and deaths in red were very, very low, really until the Delta variant hit Vietnam in June 2021. And that's when cases really began to surge, particularly in Ho Chi Minh City, where the outbreak really was. And I'm going to spend a lot of the talk really talking about that outbreak and in Ho Chi Minh City. Really over about 3 months, there were about 300,000 or 400,000 recorded cases in the city and about 20,000 deaths, and those came very quickly. But I also want to show you also the relationship to vaccination in Vietnam, which is the green arrow in the UK and Vietnam panels there. And that's showing when really community mass vaccination programs started in both countries. You can see a lot later in Vietnam. The blue arrow, however, is when healthcare workers were vaccinated. There was a small amount of vaccine available early on in Vietnam in about March and April. So it did give the advantage of healthcare workers, frontline healthcare workers were vaccinated then. And then the inset above is the rate of vaccination and progress throughout the country, the lighter green being first dose, and then progressively the two other shades of second and third doses. And what I really want to show here is just how rapidly, when vaccines were available in Vietnam, which were mainly bought, I have to say, not donated, how quickly the population were vaccinated. And I think that's important to recognize that these things can happen. At one point, about 1 million people a day were being vaccinated in Vietnam. Before I talk more about the ICU impact, though, I think it's important to understand the background. What was ICU care like before? Well, it's provided in provincial level hospitals and tertiary centres in the big cities. Like anywhere, it's expensive. On the right-hand side, you can see the healthcare spending in Vietnam compared to other countries in the region, as well as Europe and other low middle-income country average. Vietnam spends about $180 a year per capita on healthcare. So you can imagine how little of that ends up in critical care. Not surprisingly, there are relatively few healthcare workers compared to, again, the region and higher income settings. And that, again, influences the care that's provided. It's certainly common in many low middle income country ICUs that relatives have to come in and provide care, basic care for patients. And that was impeded and prevented in COVID as well, which was another strain for healthcare workers. It's fair to say that the facilities available are very varied. So some of the tertiary centres actually have very nice looking facilities with things like ECMO, centralised monitoring. But in some of the other facilities, there's a lot less available. There's a very varied case mix that we see. Vietnam is predominantly still a rural population. There's a lot of poverty and malnutrition, but again, there's increasing urbanization and a rising middle class. We're seeing obesity coming as more of a problem, and things like smoking and hypertension, again, certainly not declining like in many European countries. Our ICU is full of things like tetanus, vaccine preventable diseases, things perhaps unfamiliar like dengue, as well as more familiar things like sepsis to be dealt with. I mentioned staffing generally is a problem, but again, particularly in ICU, I think. These are the results of a survey across the region we did as part of the Asia-Pacific Sepsis Alliance. This was including some high-income countries as well, but predominantly low middle-income countries. Again, staffing was very variable, but fair to say somewhere often up to 8 patients were looked after by one nurse, or 8 ventilated patients in some ICUs. And it certainly wouldn't be uncommon for 3 or 4 ventilated patients to be looked after by a single nurse. Again, things people may not appreciate are very often units are not staffed with staff per bed available. There's a fixed number of staff and they take however many patients are required, and simply beds are moved up and equipment shunted around to accommodate that. It's really hard when you've already got limited staff to really have a multidisciplinary team. And again, we found that in our survey through the region, particularly looking at physiotherapy in ICUs. One of the things we tried to do in Vietnam to get around this is to train nurses in basic physiotherapy rehab. And they're actually really quite good at this. But again, the problem is time. They're already looking after 3 or 4 patients. So finding that extra time to do the physiotherapy is really challenging. The reason we did the survey was because it was the beginning of 2020 and we were really interested in seeing the pandemic preparedness within the region. And the graph on the left is showing the capacity that early in 2020, the ICUs in the region felt they had. These are mainly tertiary centres where they were expecting to take the bulk of COVID cases. I don't know if you can read this, but the median number of surge beds available was 10, and median number of ICU beds total per hospital was 49. Vietnam was no different. The plan was to take the severe patients to 1 or 2 dedicated tertiary centres. But we did very early on set up field centres and field hospitals for less severe cases, and particularly for quarantine. Vietnam did a lot of quarantining of contacts. So what happened really when that big wave hit in July 2021 in Ho Chi Minh City? Well, the healthcare system really needed to respond, and very, very rapidly, because the number of cases really rose very, very quickly. So the dedicated tertiary centres essentially became complete COVID hospitals, and most other hospitals and ICUs within the city had to take COVID patients. But the plan still remained to use these field hospitals. So they'd already set up some, but a lot more were rapidly set up, for example, in schools or army facilities or factories like this one shown. And rather than essentially being quarantine facilities, these started to have ICU beds. So the picture here is of a field hospital, a 1,000-bed hospital. It's got a 50-bed ICU with facilities for ECMO for about 4 or 5 patients. Equipping these centres and the hospitals in generally was obviously a massive challenge early on. But even basic things like infrastructure needed to be thought about. You heard from Janet earlier, I think, about the oxygen initiatives, and that was no different in Vietnam. Piped oxygen had to be supplied, not just to the field hospitals, but to most of the wards in the other hospitals. But even simple things like electric sockets, there were no electricity outlets in a lot of the patient rooms in the hospitals. Because the pandemic wave in Ho Chi Minh City was relatively localized and the country was under really strict lockdown, it did allow equipment from elsewhere in Vietnam to be moved to Ho Chi Minh City early on. And then as the government were able to purchase more and equipment was donated, that relieved some of the stress. But staff had to be very innovative. One of the things they've used a lot is CCTV, which was actually really readily available, but allowed patients to be monitored remotely, and even bedside monitors to be visualized. Things like wearable devices were used in some places, connected to phones or tablets as other monitors. And then staff, I've already said staff's the challenge. I think probably all of you have found that providing enough staff under these extreme conditions is really difficult. Staff in Ho Chi Minh City were redeployed from elsewhere. They were also sent from other areas of the country. but really, this was not ideal. Most of them had never worked in ICUs before. Education was a problem. Some internet events were really, really popular though, and I think it's just worth stressing how well received they were. So I was asked to say, you know, what is there still to do? Again, Janet early on talked about the inequality that still exists within vaccination coverage and vaccination access. And I think really this community really needs to continue to advocate for fair and equal distribution and access for vaccines. But we are in the legacy session, and what can we take from this going forwards? We've developed a lot of expertise, we've developed networks, and in some places, you know, some hard resources have been acquired. And what can we do with them? Well, I think it's really important that we try and address other problems that are still there throughout the region. So the bottom right-hand panel is showing sepsis. Deaths of sepsis, I think, is fairly obvious. It's the darker colours there, and they're very much concentrated in low and middle income countries. So I think the ICU community are in a really good position to capitalise on what we've learned and these bonds and networks we've developed, and really to try and address some of these issues going forwards. But I would like to just give you a final personal thought in that, you know, we want good quality evidence coming from this community as well. We heard earlier about the process for making guidelines and how rapidly these could be shared. But if the evidence isn't there, or it's poor quality evidence, then these guidelines really are not helpful. And if you have very limited resources to start off with, really making those difficult decisions about resource allocation, I think we are obliged to provide as good quality evidence as possible. So that's the end of my talk, and I'm really happy to take any questions, or thanks very much.
Thank you very much, Louise. It's very insightful to share your story whilst in Vietnam. A quick question I have is around treatment. So obviously there were lots of research happening, news was flourishing over various forms of platforms and what have you. From Vietnam, from inside Vietnam, did the drug treatments, how did that impact the way you treated COVID positive patients in the hospital in Vietnam? Did you have all the plastic drugs and things like that?
Yeah, that's a really good question, Adrian, actually. And I'd actually slightly adapted for time that very first slide that I put in, because that kind of long gap where it looked pretty hopeless, where Vietnam had no vaccines, and we were waiting for them, and the pandemic hit. I think we were very fortunate here, because in that period there were some, you know, really important trials, including things like Recovery, that were published that provided that really strong evidence base, and certainly within Vietnam, that evidence was taken on board. There were guidelines. The drugs were purchased centrally and available and made available very rapidly. Now, this doesn't include all the very expensive drugs all the time, but there are actually access pathways developed here for some of those. But I won't say it's not been difficult, particularly in the provinces, as the wave spread out to the provinces. Certainly early on, there were certainly shortages of drugs. But a kind of very centralized system seemed to be fairly effective. But it was at the expense of some other drugs, because people focused on things needed for COVID, and people coming in with other diseases, the supply chains weren't quite so strong, I think.
Thank you.
Well, thank you. I've listened also to your presentation. Thank you very much. And I was wondering, you presented on the workforce demands, and of course it was very difficult for the staff, difficult conditions. And I also know from literature and from other experiences that there was a high emotional demand. Could you explain a little bit? Did you have some strategies or support for the people who worked in the ICU?
I think that probably depends place to place. One of the strategies, which was probably not intentional, was that when staff were redeployed, they tended to be redeployed in groups who already knew each other and worked together, and that gave them already a kind of fairly strong bond to move. For example, moving across the country, they would tend to be kept in the same teams. There were initiatives in a sense. There were a lot of public donations of food and gifts for staff, and I think that made a big difference. And indeed, they continue to flow in really. And, you know, a general appreciation within the media and society of healthcare workers. But I think it is an ongoing problem. I think it's a huge demand for, as we all know, for staff, and something that we're still really coming through the pandemic in Vietnam. And I think it's something that we need to continue to look at and try and address as we go forward. Yeah.
Okay, thank you very much. I do not think that there are any questions from the audience. No, I see Adrian. Okay, well then thank you very, very much for this excellent lecture. And maybe we can have some questions at the end of this session. For now, it's my honor to introduce Professor Dr. Stefan Schaller. He currently works at the Department of Anesthesiology and Operative Intensive Care Medicine at the charity Universität Medizin Berlin. He is Professor of Anesthesiology, and he is the Deputy Clinical Director for the Campus Mitte. He's also the chair of the next committee of the ESICM. And so it's my honor, and I would like to invite you to talk on if we still can attract the healthcare workers to our ICU. The floor is yours.
Yeah, thank you very much, Margot. Dear ladies and gentlemen, dear colleagues, it's an honor for me to talk here at the ESICM Alive Solidarity Marathon about can we attract healthcare workers to our ICUs. As Margot already said to you, I'm the chair of the next committee in the society, which represents the young intensivists within the society. We have learned in the last 2 years in the pandemic that an intensive care bed alone does not guarantee intensive care. Without qualified healthcare staff, a bed is nothing. And we also experienced that the ICU community, doctors, nurses, allied healthcare professionals, are a highly flexible workforce. We were able to increase intensive care beds by including non-trained staff in our workforce with minimal training. For this need in the last 2 years, the European Society of Intensive Care Medicine was able to react very quickly in a very short time and provide the necessary resources to our members and the intensive care community. We have trained over 20,000 healthcare workers in the European Union during the pandemic with our C19 Space program. It's a preparation skill course program which consisted of webinars and then also sessions on campus with visualization, as you can see here, with these goggles, using your own smartphone. This program, as we have just published, increased the knowledge of nurses and doctors, normally not working in intensive care, significantly in basics of intensive care medicine. And thanks to the European Commission and our society's leadership, this program is also now available freely for everyone globally. And together with the WHO, we are also trying to translate it to several languages. We also have been told before, and I'm pretty sure you know this presenter, which I'm showing you here, that we have to take care of each other and ourselves. Because the crisis as the pandemic and also the Ukraine crisis at our hand are not sprints, they are marathons. And even more, we did not really get a break between these two marathons yet. I think this is also very important when you think about workforce. So marathons, like the pandemic and the Ukrainian war, have consequences and tolls on our workforce. We know that the pandemic had an extreme impact on our workforce. We did a cross-sectional survey amongst intensivists, part of the European Society of Intensive Care Medicine, and got over 1,000 completed questionnaires returned. These data here show that 51.8% reported high levels of burnout after the first pandemic wave. That's the majority of our staff. And factors independently associated with symptoms of severe burnout were age and the clinician's rating of the ethical climate of the ICU. So this supports the necessity to create structures within the ICUs, such as psychological support or resilience training, to keep our staff mentally healthy, but also the importance of an ethical climate, meaning how ethical issues should be handled within our ICUs. But let's switch and continue with the future direction. The attractivity of an ICU as a workplace is defined by internal and external conditions. The demography of our patients is changing. The number of older and frail patients are increasing, shifting the care needs and making the ethical climate, as I just talked before, important. We have different generations working at our ICUs. The needs of these different generations have to be met by adequate leadership and individual approaches to their specific needs. A culture of interprofessionalism and multidisciplinarity supports the optimal patient care in the complex setting of the ICU. And these cultures must be established and exemplified again by leadership. Digitalization has the potential to make work easier for healthcare staff and to further improve patient care. Unfortunately, this is often not achieved with the isolated solutions that have been available up to now, which tend to increase very often the documentation burden. The further development and implementation of already technical solutions in digitalization will be significant for further development both in clinical care and in research. As an example, our university hospital in Berlin provided telemedicine care for other ICUs to improve quality of care during the pandemic waves. And it was now expanded with a global parts with the WHO in some other countries providing care and assistance in other countries. Last but not least, communication has and will be a fundamental part of ICU care. Communication between the professions and disciplines enables high quality patient care, while communication with the patient and the relatives is an essential part of understanding our work as well as processing what happened to them. So what goals should we have to improve for our patients, our healthcare workers? We have to continuously improve the quality of treatment of our patients. I think this is easily said. However, we have to improve the staff satisfaction in order to retain our staff, to be an attractive workplace, to enable recruitment. And recruitment has become really a challenge, especially in Germany for nurses and allied healthcare professionals. And due to the shortage of personnel, the search strategy has often been extended to the global market. This requires not only support with relocation, recognition of documents, but also linguistically and culturally. We further have to evaluate the evolution of team roles in the ICU, which has become an interprofessional and multidisciplinary workplace. The roles and competencies have to be defined and communicated, and I'm pretty sure will be further adapted also in the future. Last but not least, the processes and interfaces in the ICU workplace have to be adequately modeled to fulfill the patient, relatives, and healthcare workers' needs. So attractiveness to our ICUs, I'm pretty sure, will increase with good leadership and an appropriate cultural code. The classical hierarchical leadership structure will still have a role in certain instances like emergencies or disasters, but should be accompanied by network structures without hierarchical levels. These hybrid organizational structure should be accompanied by a cultural code where people should work together on a task, treat themselves and the patient with care. The processes and the roles should be clearly defined, with the single person taking responsibility and be committed to his or her role, while the responsibility for the final result, the patient, and his outcome is shared. Such work environment is facilitated by transformative leadership. Transformative leadership provides an idealized influence through an optimal role model. The co-workers are inspired and intellectually stimulated by the work, while the work environment and leadership provides individualized solutions for each staff member, for example, regarding working times or career development. So the right thing for the right time. We need modern personal development concepts with qualification mix in the ICU and perhaps virtual reality simulation in the future. We need personal retention concepts, as I've said before, and the interprofessionality and multidisciplinarity must be lived to keep people in our ICUs. Individualized approaches for each staff member must be available, as I've said, the right task for the right phase of life. And mental or psychological burden must be prevented, psychological support for the team available. Leaders should encourage and enable development, diversity, and innovation. A culture of team spirit, trust, pride, and courage should be present at our ICUs. And with that, you will be able to work as a team to treat the patients in the highest quality. That I'm pretty confident. Thank you very much.
Well, Stefan, thank you very, very much for this inspiring talk. I can only agree what you have presented because it's important to keep the healthcare workers in the ICU. And you was addressing already that you have to keep them and you have to attract them. What can you do to take care of the new models of working in the ICU? Because I think that might be an important thing. How are we going to do that? To work together and to have that presenting on leadership. How does it work in daily practice? What is going to change, for example, tomorrow for me working at the bedside?
Well, I think, before it changes for you personally tomorrow, I think some things around have to be changed. I give an example. We had in our COVID ICUs psychological support, and that was and this psychological support was available for the people, for the workforce, but also helped in communicating with the relatives. This was very much appreciated. And so our people, nurses and doctors, now really want this psychological stuff also at the other RCOs. It's now, for my institution at least, it is in the contract with the nurses. They have negotiated that it will be done, but it has not been fulfilled yet. But it's, the step forward is working in this way. And I also believe, to have time for appropriate leadership, staffing has to be adequate, so that you have time for education, that you have time for career development. At the end, you need enough staffing so that you can have time to fulfill these things. And this is also a thing where we have to work on. At the moment, at my institution, the goal is very much to increase the workforce, especially in nurses, and also to decrease number of patients taken care of by nurses. But it's not done overnight. It's a process.
No, I agree, and I can talk an hour for that. But I think Adrian has a question also.
Yeah, and I could talk for hours on it as well. But Stefan, really good talk again. I'm torn because a lot of the issues that you highlighted and challenges you highlighted are also issues I face in my intensive care unit. I'm going to be a bit of a devil's advocate and ask you for your opinion. So let's say you've got a nurse coming to you who works on your unit. She's been redeployed, and over the last 2 years, it's been incredibly challenging. She's had to look after more patients that she's used to. There's the moral injuries, there is the more shifts, etc. What would you say to her to persuade her to stay in intensive care as opposed to work in, I don't know, a dermatology clinic or something? What would you say to that nurse?
Well, I would say, why did you choose to work here in the beginning? I think intensive care, it's always a complex environment. But on the other hand, it is also rewarding. We take care of challenges, situations, and patients. And we see, especially if the patients visited after some time, sometimes we can't believe what we have achieved with them. And I think, we have to focus that at the end, we all together want to improve long-term outcomes for the patient, and that we have to shift by all these other organizational problems, that this is still the focus of our care and our motivation.
Thank you very much, Alan. Going back to the basics again, I agree more. I'm sure Professor Azoulay, our last speaker, will touch on that, and we can perhaps talk about it in the discussion as well. So it's my pleasure and honor to introduce Ellie, who perhaps doesn't need any introduction. She's Professor of Medicine, Specialty Pulmonary Medicine and Critical Care. He's Director of the Medical ICU at St. Louis Teaching Hospital in Paris. His CV is very, very impressive. He's the director of French FAMRIA study group. He's the past chairman of the Ethics Society of the European Society of Intensive Care Medicine. Was the editor-in-chief of the Intensive Care Medicine Journal. He's the president-elect of our society. And he's now going to talk about an area that I know he's very passionate about, which is caring for the carers.
Thank you very much. Thank you, Adrian. Thank you, Louis. Thank you, Margot. And I'm very happy to lecture after Louise and Stefan for your two amazing lectures, and I will try to follow with some ideas on the carriers. My presentation will be surrounding the COVID-19 pandemic, but a little bit more. So years before the pandemic, we knew that our healthcare providers present with many different symptoms, but the common point is that we are having the same determinants of anxiety, depression, stress, perception of inappropriate care, and moral distress. We are lost in symptoms and syndromes. Burnout has been one of the symptoms that has produced a lot of research for one single reason. It's because it's one of the major determinants of job leave. And as just has been presented by the two previous lecturers, we are in a situation where we are in a so huge personal shortage with people who are sometimes here, but in a very difficult situation. So then we are thinking on burnout much more than on any other condition. But all the other symptoms and syndromes have the same determinants. One common point to all these symptoms and syndromes is that we need to apply the 3R approach. One is us as ICU healthcare providers, colleagues of all nurses and doctors in our ICUs and other allied professionals, as well as ICU leaders. We need to recognize and watch for the warning signs. We need to be able to reverse so that we intervene as early as possible. And we need to help our colleagues to build resilience. And I will present a paper from one of our chairman, Margot, an amazing paper published in BMG Open that provides very nice and very conceptual options to get to help our colleagues to build their resilience. So during the COVID-19, and these are data from the second COVID-19 wave, we have had so many symptoms in our colleagues, symptoms of anxiety, 60%, and we are in the common ranges from the literature, symptoms of depression, about 40%, burnout, 45%, and post-traumatic stress disorder, almost 30%. Added to that, we have insomnia, and we still don't know what's the healthcare provider's trajectory and whether we should target anxiety and maybe improve our colleagues, or maybe target insomnia, or if insomnia is not one of the targets, but one of the consequences. What we know is that the predictors of these symptoms are, of course, based on respondent characteristics, sex, profession, experience. The nurses, our colleagues who are women, have always more symptoms, and we need not only to develop, but also to apply specific strategies for our colleagues. We need also to improve work organization, that is not only to be able to rest, but also to care for family. And there are also all the self-perceptions. Fear is one of the major symptoms that we need to target, and we need still to target it outside the pandemic. The pressure from the surge, the intention to leave the ICU, lassitude, working conditions, and all those clinicians who missed the clapping in the subsequent waves are those who presented with more symptoms of PTSD, moral distress, and burnout. Looking at the literature before the COVID-19, we have also a high prevalence of burnout, but certainly less than during the COVID-19. What we know, and this paper has been presented by Stefan, we have joined our effort to collect data from ESICM members, and with more than 1,000 answers, we are able to report the global prevalence of the symptoms I just presented, but also how it varies across regions of the world, across countries, and across continents. There are variations, but still we could say that prevalence are high everywhere. When we look at this systematic review from 11 studies where the prevalence of burnout was around 50%, we again see that nurses are at high risk, that there are socio-demographic factors that expose healthcare providers to more burnout. But there are also many pandemic-related variables that have produced burnout, like the shortage in resources, the worry and the fear, as well as the stigma. At many places in Europe, we have had many stigma in different ways, but for everyone at the end of this pandemic. This is one of the papers that we produced on anxiety depression. But one of the interesting findings here is the high prevalence of peritraumatic dissociation. Peritraumatic dissociation is a mix of disbelief, you are not really capturing the events that are present, but also a kind of a mix of anxiety, making that you are not able to cope with the situation. You have the feeling that everything is okay, but actually you are at high risk of post-traumatic stress disorder. I would say that these symptoms of peritraumatic dissociation are those exploding to PTSD. And what we can see here is that the nurses and the nurse assistants and people who had less ICU experience had a very high level of peritraumatic dissociation, and we know that they are going to report a lot of PTSD afterwards. So us, us, one of the major things to do to apply the first R, which is to recognize, we need to have some elements to recognize burnout. And we did a cartoon for that, for our nurses to be able to know what we are talking about. So there is a very big difference between stress. Stress, you are here, but you're stressed, you're a little bit with emotions and with difficulties in coping, but burnout, you're not here anymore. You are too tired and you have left the ICU. Stress is too much things, too much engagement, too much emotions, too much loss of energy. But burnout is when you have the feeling that you have not enough engagement, not enough emotions, not enough motivation, and you are getting to be detached from your current practices. You are getting into depression, and the primary damage is emotional, is not physical, and this is burnout. You spend your nights thinking on work, and you spend your days thinking on sleeping. This is another typical feature of burnout, and of course, no one will come and complain for burnout. You need to recognize, you need to ask people how they feel, if they are overwhelmed, if they are vulnerable, if they are delusional, if they are helpless, if they are hopeless, if they are completely worn out, and if they are losing motivation. You, and as an ICU leader, and us as colleagues and friends, we need to help our colleagues to screen and to recognize the first symptoms. The feelings of burnout are very different from one setting to another, and we need to know if people complain that they have no control over their work. They will not say, I have burnout, but indirectly, you will be able to recognize that people feel that they are not rewarded for a good job, that they work in a chaotic environment, and Stefan just reported on ICU climate. They have no close supportive relationship, that they have not enough sleep, that they have too much work, and we need to be able to recognize these feelings because we are dealing with people having burnout. There is a very clear clinical approach, making differential diagnoses between burnout, depression, stress, anxiety, and other feelings like moral distress, etc. Moral distress is more related to something that is in direct relation with care, with excessive care, with the perception of excessive care. But here we are more into the feeling overextended, emotional depletion, physical fatigue, discouragement, and you have per domain of burnout, you can understand what are the different signs that would be very appealing and would help us to recognize our colleagues at risk for burnout. In this study, that was one of the first studies published from the Chinese data from the first wave, a large number of healthcare providers responded, and one of the target that appeared was insomnia. We can consider that insomnia is reported in up than 40% of our colleagues managing COVID-19 pandemic, mostly in nurses, in women, in people who are frontline, those working in China, in Wuhan at this period, but we can apply this to our settings, and reporting different degrees of mental health symptoms. We know that insomnia is also a way to keep our symptoms of anxiety and depression. Insomnia is also reported here in 40% of the frontline healthcare providers, and these are data from more than 33,000 participants, showing really that we need to understand what are these people's trajectory and know whether it is a target, and we are currently working on that. This is another paper that was before the pandemic, and again, it reports on the perception of inappropriate care. And these data from Dominique Benoit in Ghent that have more than 10 years are really reporting how much the care of our patients can produce this perception that we do too much, and sometimes not enough, but we are mostly doing too much. And we need to consider that communicating, improving communication, improving our ability to respond to patients' preferences and values would be a very good way to keep our colleagues, but also to improve their wellness at work. Of course, the perception of inappropriate care is when one doctor is leaving the room and is not caring enough for one patient who is dying. And we know that these situations are very complex and very poorly perceived by the nurses, having the feeling that the patient is hidden behind the techniques and that we are not caring for someone anymore, but we are caring for a clinical situation. So now how we can reverse, and we know that there are many different options, but a very little level of evidence in the literature. Again, we are working now on trying to understand the trajectory to know if insomnia is something that is an early symptom that will have difficult consequences, or if it's the result of all the symptoms we just mentioned. We know that from this study that if we want to look at the determinants of mental health disorder, we have the fear, we have the inability to rest, we need to care for family, we need to struggle with emotions. We have really felt very badly about the visitation policies that were too much restricted in our ICUs, and we have witnessed hasty end-of-life decisions. We know that these are targets, and if we want to improve the mental health of our colleagues, we need to also target these elements. There are, of course, ways to reduce the burden and try to improve. This study on mindfulness, yoga, and music was able to report that when we have a very high level of burnout and burden and mental health symptoms in our colleagues, we can have this kind of strategy. But I would say, by definition, it will be less efficient because we are quite late and we are only treating the consequences of the mental health symptoms. Another way to really reduce burnout, and this is the only study that has been interventional, even though the design is a before-after interventional study, you can see that you can reduce burnout in nurses and health nurses by only improving communication and end-of-life practices. And for sure, this is something on which we will work. ESICM is working on that, but we need to understand how we can approach this at a global level and find options and solutions that may be easy to apply everywhere. Again, a call for actions to professionals, to ICU leaders, to nurse managers, medical directors, hospital administrators, funding agencies, and professional societies, as we are really important because everyone has a role in this global puzzle to be able to contribute to a little bit of reduction in the mental health symptoms in ICU nurses and doctors of every age. Again, to help people build resilience, there are many different options, but these options are common to every different system. This is the paper, and this is the paper I was mentioning, and this is a thematic map of factors contributing to vitality and resilience, and we need to understand that to really develop collaboration and safety and connectedness at work, we need to really have a very good mapping of how our colleagues are feeling and what we can do for them. So every ICU should have a working group and every department should work on that to be able to adapt this kind of thematic map to every different setting. And again, targeting communication and end-of-life practices, improving mental resilience, and really having feedback from everyone are really, really needed. Thank you very much for your attention, and I'm very, very happy to be part of this live ESICM marathon webinar. And we are really very happy and supportive of everyone involved in any kind of war and disaster, because we are together. Thank you very much.
Thank you very much, Ellie. A question. So in your talk, I think a lot of the themes that you originally talked about will be familiar to all of us on the panel and the colleagues everywhere. Touching on burnout and what you would do. So there are things that you can do at an individual level, but equally, what I think most of us would agree that the organization or higher up intervention is probably more important. Again, playing devil's advocate, whose responsibility does it ultimately fall down to if your staff are burning out? Your thoughts? Management or individual?
Well, it is connected. I don't think that we can report on only one of those, and I think that the question is more for Margot than for myself. But still, we need to look at the system, and we need to have a very comprehensive approach of our individuals. Of course, there are determinants that are personal to the people who are affected by the symptoms of burnout. And in one of our studies, personalities, for example, if you use a very simple MBTI, you are able to connect this to the ability to develop symptoms of burnout. So there are individual factors. I'm not saying that some people are not able to work in an ICU. This is not at all what I'm saying. I'm just saying that we need to adapt our solutions and our ways to manage this to individual characteristics. Two, one of the major things is the ICU climate, the way the decision-making is made, whether we are able to involve people, to just discuss, sometimes to wait, sometimes to not have the same behaviors for everyone, to accept patient trajectories, to respond to family requests, and to basically base our decision-making on patient preferences and values. This is relieving for everyone in an ICU. But this is not the solution when you have your high level, the high level of burnout that you reported on. This is something that is preventive. When we are in the state that you reported on already high levels of burnout, I think that we need to reorganize our work environment. And I wouldn't say that this is easy. It takes time. It's not something that we can do on our own. And I think that the teams need to be connected, where I always say that an ICU team is a pilot and a co-pilot. I don't see myself working without my nurses. I don't see myself connected to anything without the nurses. We need to talk to family members with the nurses, and we need to talk together. And I don't see how we can do otherwise. But if this doesn't exist in one ICU, I think we can implement that, but it takes time. For that to happen, there is a major need for all of us to recognize the situation. So external eyes are very good for that. And we need to have people in our ICUs maybe more keen to look at that and to screen our people. I would say that this is our global and individual responsibility, but ICU leaders, doctors and nurses need to have a careful eye on that, because prevention is much better than anything that will be curative. We know how to cure burnout. It takes time. There are strategies. We know how to do. However, I would say that when someone is on leave because of burnout, you have not only lost a clinician, but you have also lost someone in your ICU. And I think that this is the time zero after which you cannot wait anymore to implement really curative strategies for everyone. When you have one case, it just says that this is the top of the iceberg and that everyone has certain level of symptoms. But this is also a question for Margot.
Thank you very much, Ellie. Margot?
Yeah, of course, and I only agree with you. And I think this is very important that we have a good teamwork. And of course, in that you have to work as an intensivist together with the nurses. And I think that is one of the most important things to prevent that people are draining out emotionally or going into the burnout or have, well, I was really surprised with your pre-traumatic dissociations because what I see, what we do a lot as researchers, we use a questionnaire, for example, for burnout or for having post-traumatic distress, and we say, hey, well, we are all traumatic. So it's very important to have a good preventive strategies, and you have already mentioned a lot of these. And for myself, I couldn't agree more that we need the social togetherness and that we have an eye on each other, and that is one of the most important things that we have as a team in the ICU. So I think that could relate to every talk of us. And because of the time, maybe there is some short, last word of you that you could add to this wonderful session. Adrian, do you want to?
Well, I've really enjoyed the sessions because this session talks about looking after ourselves and our colleagues as opposed to patients. Yeah, it's often a neglected aspect, but it's really important to us. So as a way of closing to our expert panel here, what do you think has come out of the COVID pandemic that you implemented on your unit that you think should be taken forward for future and become the new norm, if you will? Louise?
I don't get a minute to think of that one. I think it's forced us to think about the way we work. Looking after each other, I think, is really important. I think probably just appreciating you. We all talked about looking after each other, and I mentioned the closeness of the teams that we already had in Vietnam. And I think going forward, I think that's something that we will continue to do, working together, supporting each other, and also, using our networks. I didn't say in our talk, I know we haven't got long, but, we have been supported by many international friends overseas. And I know from the team in Vietnam, when things were really bad, we'd have a Zoom call with somebody from the UK, for example, and sharing those experiences really was very, very helpful. So thank you.
Stefan?
So three things, actually. First, psychological support, as I've told in my talk, then also telemedicine consultation, which we have now at our unit available. And also the third one is PICS outpatient clinic, so post-intensive care syndrome outpatient clinic. We developed these things in the last 2 years during the pandemic.
Ellie?
I would say also three things. The first one is to make everything that the rounds are made together by nurses and doctors. I think that this is a basic rule. But I would say that over the last year, it was something that we lost from time to time. And when you are able to assess a patient together, including symptoms, including talking about decisions and the way we are going to approach the decisions, I think that this is really, really healing for the entire team. The second thing is asking people how they are. And I think this is new. We are living in an environment, and I'm sure that in all our countries, there is a little bit of pudor, and we don't dare asking how you are, how do you do, is your family okay, were you able to go and do this and this with you, the people you love, etc. And I think that we have lost this pudor. We are speaking more together, maybe because we spend so many hours together dealing with crowded ICUs and the surge, etc. Maybe we are maybe more able to do that. The only thing that we didn't yet, we didn't start again is to eat together and to do, for example, having tea, coffees, etc. Because COVID is rising again here in Paris, and we are looking forward to, to having these barriers disappear, so that we will be able to have some social life together and share, time and good moments, because this is very important for a team to be able to be, aside and not only working together, thinking, sharing, and even sometimes, commenting. We have the presidential election soon, so I'm sure that would have been a very good topic for discussions, but we can't.
Well, thank you for these closing words, and I think we are going to an end. Thank you all for your inspiring presentations. And to finally finish, I would say, together we are intensive care.
We are.
Wonderful. Thank you very much, everyone.
Thank you.
Wow, that was something, Ellie.
Wonderful, wonderful, and we learned a lot from everyone. That was a really, really good time.
No, it was an excellent few hours together, and I've little to say, really. It's so heartwarming to see so many speakers, the technical teams, everyone involved, the sponsors, our members. Everyone is really supporting these initiatives that are allowing us to do all these free initiatives for the global intensive care community. And for me as a president, it's just fantastic to see this. Just a plea to everyone, if you can donate, to ask a friend to donate to the Alive Fund. It allows us to carry on with all these free activities in low and middle income countries and in other places where it is needed. And with this, I would like to give the word to you, Ellie, for the closing remarks.
Yeah, I'm sharing everything you said, and I would like to remind to everyone the thing that we were sharing this morning, Mauricio, is that no one refused the invitation to take part to this. No one that has been approached didn't say, well, I can't, I don't have the time. Everyone was ready to help, everyone was ready to lecture. As you said, the sponsor and every kind of support, and the ESICM office has also been amazing. And I think that we are in a common effort, and everyone is very enthusiastic, and we know why we do that. So together we are intensive care.
Together we are intensive care. Bye-bye, everyone.
Thank you. Bye-bye.